My name is Josh Joseph. I'm the chief computer nerd or something like that for Mass General Brigham. I'm an operations research specialist, and I'll be giving the first talk. The way this workshop is broken up, it's very informal. Obviously, this is like a fairly intimate group. This is not like the Emperor's March kind of room next door. So again, feel free, maybe not to interrupt us mid-talk, but we'll have time for questions, we'll have time for Q&A. These are brief talks. We'll allow you guys to mingle, stretch, et cetera. And then we're gonna have a panel at the end. So without further ado, I'm gonna start just on kind of the broad topic of operations research. Again, people are coming here from different backgrounds. I've given this talk in various forms to residents and fellows with some additions to medical directors and Medical Directors Academy. And again, this is a topic that I've devoted my career to. I think it's really important. And it's also one that I think actually affects people in a lot of different walks of life in emergency medicine. Not everybody's a medical director, but I think in some ways every single person who works as an emergency physician is actually involved in operations. And there are many roles within emergency medicine that still in many ways do operations research. Anytime you are putting in a clinical care pathway, you're doing operations research because you're affecting the flow of patients and the way you do business. Before I just give you the entire talk before starting my PowerPoint, again, I'm from Mass General Brigham. I have no disclosures, but I'm open to any. Meet me after the talk. So again, the question of why researching operations is one that hopefully you guys have signed on for, sight unseen. But to give you a little more kind of insight into the topic, for the medical student out there, for the resident who says, why do I have to care about operations? Isn't that the role of my chairman or my medical director or the administrator who's not an MD? Well, I'd say, you picked up a patient with belly pain, a patient with an ankle sprain, and the question of who you ought to see first would seem straightforward, but sometimes it's not, especially if you're alone in a single coverage ED, and maybe those are the two patients who've been brought back so far, but you have no idea what else may lie for you in the waiting room. So again, as emergency physicians, if you're on your ABEM general board exam, you see the sickest person first. There's no question about that. But if you're trying to manage an emergency department and trying to manage the workload of both yourself and a team of nurses overnight, should you maybe actually see the person you can get out of the emergency department first if they're really straightforward? And again, it's the sort of thing where you might think about when it's 2 a.m. and there's suddenly 30 people in the waiting room and you have to decompress the emergency department. Isn't there a way that we could do some part of this better? Could we get patients back from triage better? Could we get some of those tests that really seem pretty straightforward from triage a lot sooner? Again, somebody who's got a concerning looking ankle, they twisted it, but it's really swollen and bruising. That person probably will get an x-ray one way or another. Ottawa rules aside, if it looks bad, people will probably get x-rays. If you already had those x-rays, you could probably make a disposition a lot faster than if you have to send them for x-ray, come back, and so forth. And again, admitting patients. I work overnights primarily. I have to admit, the hospitalist really likes it when every single test, including the UA, has come back so they can really be sure that there's not that hidden UTI, which somehow would preclude them from being admitted to medicine. But as a result, we seem to get that back at 6:50 a.m. And I call up and, need the admitting hospitalist. Oh, sorry, I'm headed out. Well, I'm headed out too, but my patient needs a dispo. I can't just leave them in the lurch. Or, I can sign them out to my colleague and then have my colleague who's never met them sign out this patient. They know, exactly all of what I've written about. So again, anytime you've really thought, could we do this better? Could we do this differently? You've engaged in at least theoretical operations research. Maybe, not the most productive, but these are kind of the germs of ideas that actually make real change in the ED. So again, there's this great saying, measure what's measurable, make measurable what is not. So everybody says it's Galileo. There's also probably some later theorists, but Galileo is famous, so we attribute it to him. But it's important to understand that for the most part, operations research within the field of emergency medicine is a really, really developing field. And again, it's ironic because we work in this era where, again, everybody has heard of ChatGPT, everybody has heard of, big data. Again, I can guarantee you that if you put big data in your talk title, you're much more likely to get accepted. You will get the C-suite involved. You may not need to actually know anything about big data, but we all know it's important. And the truth is that it really is ubiquitous. There's a tremendous amount of data that we put into the medical record. There's a tremendous amount of data that just kind of gets passively collected, generated. It's really kind of a treasure trove. Yet we know very little about many really basic things about emergency care. Again, that's not to say that there aren't some very strong efforts towards standardization. A couple years ago, Maya Dome had this really great emergency medicine summit. There's the ED Benchmarking Alliance, but again, these are kind of groups that many EDs are a part of, but there's like an administrator who's non-clinical who actually is part of these groups. And kind of the wider population of emergency physicians, for the most part, we're like not aware of a lot of these groups, or we're like tangentially aware that there's an EDBA and they've done some studies. And part of the problem is that operations are also, for better or worse, part of the secret sauce of how your emergency department and your hospital functions. Again, to give some examples of like basic measurements that I still can't really give you a solid answer for, is like how many patients an hour a resident ought to see. Like again, I had a resident come in who's very interested in operations, and she's like, yeah, how long does an average history and physical by an emergency medicine attending take? I don't know. Like I have what I'd like to tell people, which is, probably 15 minutes of extensive questioning, 15-point physical exam, maybe not a full skin exam, but, gosh, we really go head to toe. We don't leave any stone unturned. And then practically speaking, well, there's a person with belly pain and I poke them in the belly. And that's kind of what happens a lot of the time, but there's no objective measurement that anybody's really done. And it would be, if you think about it, it'd be really invasive to do, to have maybe somebody follow you around with a stopwatch. It might be very enlightening, and it might have results that you don't necessarily want to disclose to the public. So again, it's extremely variable, and I doubt you could really say that a meaningful average would make sense as well. The person who looks great, who's just kind of like real tender in the right lower quadrant, but otherwise is doing okay, they may not really need like a 10-minute physical exam, but the person who's septic and altered and can't give you a history might need a much more extensive exam. So to say, the median time for an attending physician takes 7 minutes might also hide an awful lot of detail on those patients. But, I also can't tell you, like, probably we're a lot more efficient than our residents, but what does that actually translate into in terms of how I spend my time? Again, just working at an academic medical center, I can tell you, I field an awful lot of questions and get interrupted an awful lot of times by various people on our team. But, in terms of how much time I actually spend with an individual chart versus a resident, I couldn't actually give you hard data, and maybe somebody ought to figure that out. And again, there's a lot of safety concerns with this because, again, I can certainly flex myself up if there's really a big crash of patients. I certainly like to think that I have a really good sense of who I can spend more time and less time with and still kind of keep within acceptable parameters. But this is not really the sort of topic that's been studied rigorously. I can't tell you off the top of my head. I can tell you what a good door to EKG time is, but I can't tell you what's a good patient interaction time. So this first question, like how many patients per hour should a resident see, actually was like the subject of my early career, and it's really what got me into operations research writ large. And I'm going to kind of do just a very deep dive on this topic. There's definitely not time to like tell you about every single area of operations research in total. I'm going to touch on some highlights, but this has been just like one question that has given me like a lot of work to do. So, because, just talking about how many patients per hour residents see kind of provides all of these other sub-questions, how much does sign-out really contribute to your productivity? If we have 2 resident shifts and one takes kind of a normal team sign-out and the other is this like free-floating resident shift, is the free-floating resident like dramatically more productive than the person who gets bogged down with a lot of sign-out? Does it really matter, a resident who's like super confident and sees a ton of patients like right as they come to the emergency department, do they ultimately see more patients? And are the experiences of residents versus attendings, I just gave the example of like being able to like sort of tell when I can spend more or less time with a patient, does that experience actually translate into meaningful differences in how I do my job? I mean, like, again, I can think of a lot of ways it's different, but in kind of an objective way, is there a way to quantify that? So I wouldn't say that I've, massively changed the outlook on this one topic, but I'd like to say I've had some meaningful studies that maybe have pointed people in better directions. So there were a couple of papers out there when I started looking at this topic, and almost all of them tended to kind of look at resident productivity as a very static number. You are a first-year resident, you see 1 patient per hour. It is such, maybe there's a little bit of kind of fuzziness in here, but on average, it's 1 per hour. By the time you're a second year, you're twice as good as a first year, and then there's maybe a period of diminishing returns by the time you hit third year, and 2.25, maybe you've got somebody who's a real stud and can see 2.35 or something like that. But to be honest, like, how many of you think this is actually how residents perform? Show of hands. This model is like a good representation of reality? No, nobody's raising their hand. I get a lot of head shaking going on, and that's true. So just looking at the residency program I was at the time, it was all over the place in terms of how many patients per shift we're seeing, how many patients per hour of the shift in particular we're seeing. And it was this kind of like crazy looking curve. Here we have the interquartile ranges, which are just all over the place. And this kind of went in with the experience I had. There were certainly a lot of folks who came in and just worked kind of relatively slow and steady. And then we had some people who were, as far as I could tell, like really, really nuts. We found a resident who saw like 6 patients in their first hour, more than once. And again, here you start to wonder, is a resident really like fully seeing 6 patients during this first hour? Because they also have to like present them, put in orders, hopefully document at some point during their shift, maybe afterward. And then they've got to kind of like deal with all the fallout from having taken care of those or signed up for those 6 patients. So, there are all these other kind of issues that came up. And so what actually happened when we really drilled down on the data was that there were a couple of different phenomena going on. So, somebody who suddenly sees that there are like 4 ankle sprains in the rack when they start, yeah, they credibly probably could easily pick up 4 patients and dispo them really quickly early in their shift. But trying to be really, really eager at the beginning of your shift comes with a price. And as I alluded to, there's all the work that you actually have to do to take care of, disposition those patients. And what actually tended to happen is that one way or another, if you were a really kind of fast out of the gate resident, or if you were a relatively slow and steady resident, a lot of this did even out. Now again, it was never a matter of like, there's a robot resident who just sees like the 2 per hour like without fail. But for the most part, it was just kind of like, you hit a wall eventually, and just some people hit the wall a lot faster and some people hit the wall a lot slower, because again, what ends up happening is that you sort of can see, if you just kind of like assume that you're going to hit an average curve, you might really get kind of messed up toward the ends of your shifts. And kind of, again, to go into the why, we can engage in just like a little kind of clinical operational thinking here. Now, this is super simplified, but a lot of people like to say that emergency physicians multitask. And we do, but we don't multitask in the way that like your computer multitasks. Like, we don't like ideally put in orders for other patients while we're interviewing other patients. Okay, well, maybe some of us are guilty of having done that at some point, but usually, if you're like putting in a central line, unless somebody's taking verbal orders from you, you're really kind of just doing one thing at a time. But you're often doing like one thing at a time for many different patients in a row, and not always in a totally straightforward order. And so this is kind of what's known as sort of pipelining. We'll get into that in a minute, but basically, your life as an emergency physician kind of consists of just sort of stacking the patients you see. You sign up for one, you see them, you put in some orders, and then you wait. and then you ideally have the bandwidth to see another patient. There's another patient in the rack. You pick up another one, and you just kind of keep adding this process till you either get sick of it or, more likely, you get interrupted. There's something that happens with that first patient or maybe that second patient, and you have to deal with it. The x-ray comes back. They don't respond to morphine. They feel better, they want to go home. There's some new update that you now have to deal with, and that interrupts your ability to see that next patient. But ultimately, if we don't have answers to questions like this, if we don't have the kind of insight necessary to see, like, why do we see these vast changes in productivity, in throughput? There's not a lot of ways that we can rationally design a schedule. If we kind of go back to that paradigm and just say, okay, on average we see 2 patients per hour, well, you're going to end up with a schedule that really won't match up very well to demand. Again, you could say, well, you know what? We'll just put all of our residents on one big team, and we'll have, 3 shifts a day. And, because we have all of our residents on at the same time and they all see the same number of patients, well, during busy times, we'll just have more residents. But that elides the fact that, again, there's that huge slump at the end of your shift where you're just kind of like running out of steam, and there are all of these patients you're juggling, and you really don't have the bandwidth to pick up another patient. And if you align the shifts that way, you're going to get a really nasty surprise in the 2 hours before shift change. The new team will come on, and they'll suddenly have this massive surplus of patients to see. And conversely, if there aren't a lot of patients to be seen relatively early in the shift, some of that capacity might get wasted. So again, if we can't measure these super basic things, we really don't have meaningful solutions to any of these questions. These are, as far as I can tell, really important questions in terms of how you run your ED. And it's really nuts that for many variables within operations, we just don't have this kind of granular data. So ultimately, why don't we have better operations research? I've just complained to you for a solid 10 minutes now. Okay, so why aren't we conquering this mountain right now? Well, part of the issue is that a lot of the data we look at in operations is not really smooth in quite the same way that it is in a lot of other clinical domains. So again, what are kind of units of productivity? What are units of kind of clinical work? It's really hard to define, and there are a lot of really smart healthcare economists who still probably don't have perfect answers for you. So again, when a resident sees 2 patients per hour, or they see 6 patients in that first hour of their shift, again, I'm not terribly impressed by the resident who sees 4 of their 6 patients as ankle sprains. I really rather, somebody who can competently manage 1 or 2 really sick patients and still kind of do a little bit of extra throughput. The resident who can manage 2 decently sick people and pick off an ankle sprain or something like that, to me is far more impressive than the person who comes in and just says, all right, I'm going to staff every single medication refill that comes into this emergency department. So, again, there are ways we can try and make this more of an apples to apples comparison. We can try and say, okay, well, I really care about how many patients ESI 3 and more acute you see. But again, it gets tough because an ESI 2, because it's chest pain, and it's chest pain because I got hit in the chest by a baseball, is very different than chest pain that feels a lot like my prior MI. Both of these patients might get assigned an ESI 2 or 3 just based on the chief complaint alone. But again, these are vastly different patients. And comparatively, for many of our colleagues who do purely kind of clinical research, there are really kind of concrete ways you can stratify patients. Patients who fall into one of these camps for inferior MI, they are a fairly homogeneous group. Again, not every MI is the same, but right coronary artery dominant systems tend to function pretty similarly, and you can meaningfully compare those sorts of outcomes. Another issue, as I mentioned before, operations is, for better or for worse, directly tied to the financials of how your emergency department and your hospital works. So that really brings up some major issues in terms of data sharing. So, for example, here is where I used to work last year over at Beth Israel Deaconess. It is a level 1 trauma center. It's an academic medical center. It's got many residencies, grand history, yada, yada. Here's where I work now. It's a level 1 trauma center. It's got, all these same amenities pretty much. It's like 3 blocks away. But in terms of, what sorts of data points we can easily share between these institutions, well, I can, within probably about 15 minutes, write you a data use agreement to get a multi-center study going to look at MI. We want to look at like how many patients got clopidogrel during a month or 2 period. That's really straightforward. That will get an IRB approval within like a day. If I try and say, how many work reviews do we get for those patients at both sites? That's going to be a hard pass, pretty much. And so you have to get very, very creative and very, very vague a lot of the time when you actually want to look at this like fairly essential operational data. And there are some really huge challenges we have just as a field. So it is really hard to get funding in operations research. Again, a lot of that comes from the perception that this is the business side. So again, if you're the NIH, maybe it's of interest to make hospitals more profitable, but not really. It's really your mission to help improve, care of patients who have MI, who have cancer, that sort of thing. Now again, I think a lot of that really comes from a lack of understanding of operations research. So if I can tell you that I can save like 10 minutes per patient in terms of their ED length of stay, that could massively improve care for like everybody in your emergency department. That means that, patients who are having an MI are going to get a door to EKG time that's vastly better. They'll get to the cath lab faster. There's a whole host of outcomes for pretty much any sort of emergent medical condition we take care of. It's just that trying to sell people on that is really hard. And this filters into when you're submitting operations research for publication. A lot of the gatekeepers for these publications do not come from the operations research world. For the most part, because we are, kind of a very clinically focused specialty, a lot of the research that we have comes from the public health world, and this kind of leads to a lot of problems. So there's lots of data that we take care of that don't fit into like a really good clinical design model. I don't mean to beat up too much on randomized controlled trials. They are really robust. They just work really poorly for a lot of stuff we do in operations. And that's because to make an operational change, and there are entire lectures devoted into how you even get people to accept an operational change, it's really hard to blind people to a lot of this stuff. You can't, suddenly change people's schedules and like assume they're not going to notice. Functionally, it's really hard to make like really small institutional changes, even if there's not like some grand operational theory you have. It could be that your nursing contracts change and suddenly they're doing 10-hour shifts instead of 12-hour shifts. There's going to be like blood on the floor with that kind of a change, and that may be purely because of an institutional change that nobody has power over. Compare that and say we're going to change the schedule because we think things will flow a little bit smoother, and that is going to be a Herculean task. So you're lucky if you can get that sort of change across in the first place. It's going to be really hard to do that in a way that kind of fits a trial design really well. And again, some of this stuff is really not even, it's either not safe or like totally infeasible. So I talked a lot about big data. In terms of how you make changes to your EHR, the amount of like error proofing that has to go into many EHR changes is immense. Again, there's lots of stuff that we kind of as end users don't see. And it would be unconscionable that if you actually had evidence to suggest that an EHR change would lead to an improvement, to not like trying to write the IRB saying, on Tuesdays, Wednesdays, and Fridays, we're going to have this kind of change go over, although it's a really good way of kind of doing a sort of pseudo-randomization. if you have any evidence whatsoever saying that this kind of like IT change is going to meaningfully impact patient care, you're not going to get to do it. It's going to be an either kind of choice, and once you make that sort of choice or you provide evidence for it, you're actually probably not going to be allowed to go back. So it's really, really, really hard to do a lot of what qualifies as good clinical trial design with operational changes. And so again, I don't mean to like beat up on the epidemiology world. They do, I think, a lot of really good stuff for medicine in general. It's just that sometimes trying to have this sort of parallel skill set and parallel language understand kind of what we see on the ground really leads to a bad mismatch. And unfortunately, it's a bad mismatch that works out in our disfavor because these folks are generally the ones who are gatekeepers at journals. So like, as a bit of a cartoon, but like this is my idea of like kind of how emergency medicine works. There are far better cartoons that like illustrate this, but like there also probably should be like a much bigger social media component to this. But regardless, like a lot of really successful EM researchers live in the public health realm. Again, like if you can show that a change was, like in a data set like NHAMX or something like that, I'm sure I'm mispronouncing the acronym there, you're talking about a national level data set. Does that tell you very much about like how an individual ED might implement some particular issue, whether it's, how often you're getting UAs on patients over age 65 or something like that? Not really. It really kind of tells you a lot of just like what are these really broad trends, but it is way easier to show some sort of like very small trend that's in a national data set having to do with UAs than it is to say, okay, we had just a new policy where like you get a UA within the first 30 minutes and we managed to like identify 30% more UTIs, we avoided these hospitalizations, what have you, at like 1 or 2 hospitals. One of those papers has a shot in JAMA, and it's not the one where you showed you improved patient care. And again, like part of this too has to do with like the different kind of math and all the other skills that go into what these fields are about. So again, epidemiologists, they're wonderful. They ask really important questions. They know those questions really well. They do a lot of statistics, and those statistics are really kind of built to look at these sort of very broad sorts of studies. The broader the study kind of subset, the better in a lot of ways. And folks who are in the operations world, if you meet people who have like operations research PhDs, they are scary. Like they know math better than pretty much anybody I run into within the engineering world. And that's because they have to like cover all of these crazy, crazy subjects. And as a result, they're really useful to have on board, but sometimes if you actually work with somebody who's got an operations research PhD, the amount of like math that will go into your results will make it like basically unreportable in like a regular clinical journal. And the issue is that like conversely, if you try and publish like your operational study in like an actual like industrial operations journal, it's not going to go over great. And again, it's not to say that what we're doing isn't operations. It's just not operations at kind of the sophisticated level that folks who are in industry do it. And that's kind of why we get stuck in a lot of ways. So I'm going to kind of blitz through a bit of this. Some of this is just going to kind of cover some of the basic kind of ways that operations research writ large is done, and how it kind of differs from a lot of sort of figures we may look at from public health data and epidemiology. So a lot of folks are probably familiar with regression analysis. It's like bread and butter for a lot of what we do. You have two variables. You're trying to draw some kind of relationship. I'm oversimplifying here. It's not always going to be a straight line. It could be a curved line. But the idea is that generally what we're looking at is parametric statistics, like statistics that you were introduced to in med school without going into too much detail. Whereas a lot of the folks in operations research do stuff that is like qualitatively different. Like again, it's not even the same kind of language that folks in the epidemiology world are doing. So again, say we're trying to look at the relationship between one resource or another. doing a regression is bog standard in kind of clinical research, epidemiology research. For operations research, you can pull out some very different kinds of ways of looking at data, and one of those is classification. So, you might be able to say, yeah, there's kind of a shaky relationship between these two, but a non-parametric method like k-nearest neighbors, Gaussian analysis, you may be asking what is qualitatively like a totally different question. Not, is there a direct relationship between these two variables, but are there different kind of subgroups within this setting where there might be a totally different relationship for each one of them? Again, this is not something that you will learn about doing an epidemiology PhD. And again, if you submit a paper with this kind of method, it is going to look like Greek to folks who come from that background. Again, I'm really not trying to beat up on it, but as somebody who looks at attending productivity, we did all those studies with residents. We had lots of robust data. We were like, okay, this is interesting. But again, this still kind of affects the relatively slim world of folks who do education or people who work at academic medical centers. The majority of folks who work in emergency medicine don't work at an AMC. So do attendings function the same way? That was our big question. And I was excited as a young researcher, here I was moving from what I thought were single center studies to I had a robust data set, 4 different hospitals. This is a multi-center study. This is a big deal. And I'm looking at attending physicians. So again, not looking at a microcosm, but looking at, our field writ large. So I submitted a paper looking with what I thought was fairly robust data at these multiple sites, and I was rejected in 24 hours. What did that editor who did not send my paper for review say? The productivity of individual emergency physicians does not matter. Okay, well, okay, doesn't matter how robust a relationship I can show, doesn't matter what sorts of outcomes I might be able to yield from this, the topic does not matter. Okay, there's not really a way to respond to this. You may not be surprised to know the person who wrote this was not an emergency physician. They were, however, a major editor at a major journal in emergency medicine, which will remain nameless. So sometimes you have to just look at other options. One of those is trying to publish outside of emergency medicine. Again, this is tough because you want your peers. You write a great study that shows, you've saved all those people with the UTIs that otherwise got missed. But you want your, folks to see this. But, again, it never works if you don't get published in the first place. So other options you have, healthcare quality journals are a really underlooked resource for folks publishing this space. Operations journals, that kind of comes with an asterisk that if you're really publishing in an operations journal, you probably want to talk to somebody who has an operations PhD, at least to try and get them to vet your study or help add some numbers to make things look nice and serious. But stuff that gets overlooked there are specific operations in healthcare journals, which have much broader audiences, and informatics journals actually in particular actually really like operational work because for the most part, a lot of what you will be doing to get operational data is going to be pulling from the EHR in one way or another. There are plenty of studies where you don't, but for the most part, if you are pulling data at some point from the EHR, you qualify for an informatics journal. So just keep that in your back pocket. 2 journals that really stand out, and I really like BMJ Open Quality for one, because they actually publish case reports of operational changes. So you make a change in your emergency department, it works, it doesn't work, it changes things, it doesn't change. You can actually write a paper that is literally titled, improvement in, CAT scan ordering practices through a novel intervention, lessons learned, okay? Do you need to show you have a really statistically significant difference in the before and after period? No, you don't. It's okay if it doesn't work out. In fact, that may be the gist of the paper is, we tried to do this, we instituted a change, here's what we noticed, we interviewed people, who work in an emergency department, here are the themes that came up, We improved the time to get CAT scans, but the radiologists weren't actually able to read them quickly enough, so there was no ultimate change in the turnaround time for CAT scans. This is the sort of thing that they're interested in publishing, and this can be an incredibly useful resource for other folks who are in the field. Again, I'm going over time here, so I'm going to just kind of whip through these. But again, so there is certainly a lot of crossover between kind of general epidemiology and us. I don't want to bash them all day, although I could, because they do good and important things. But it's kind of important to understand kind of where we can kind of get our studies to kind of fit into their paradigms. So again, as I mentioned before, there's lots of data out there that we don't have great measurements for to begin with. A lot of the what is sorts of questions, how many patients per hour do we see, how long does that history and physical take? Observational studies are fundamentally what we do the most of in operations research, followed by quasi-experimental studies. Again, we made a change, we have the period before, we'll compare it to a representative period afterward. Again, if you're doing a study at an academic medical center, there are some subtleties to this. So if you institute a change in July, which is honestly when it's often easiest to make a major change, and you compare data from the 3 months before to the 3 months after, you may run into some problems. So generally, if you institute a change in July, and you want to study the next 3 months after you make that change, the period that you really should be comparing to is last July through September. And again, there are even though people tend to scoff at this as a clinical design, there are incredible subtleties that really need to be dealt with even to do this sort of study, even though there isn't necessarily a lot of blinding or controls or stuff like that. Qualitative interview studies, this is absolute gold for a lot of folks in operations. And it's a little weird because this is really much more of kind of a social science paradigm. What you do in a qualitative interview is you do a lot of interviews, but what you do is you kind of come together with a set of kind of guided questions, and you interview a representative sample of folks. Again, that might be if you make a change in how you do sign out or something like that, you would interview attendings, you would interview residents, you would interview nurses. You may even interview, depending on who the sort of team is at sign out, you may interview folks who are, care technicians or whatever your kind of health assistant position may be. And you try and get a reasonable cross-section of that group. You record the interviews, you transcribe the interviews, and you and your study partners read those interviews and basically come up with a coding to look at the themes during those interviews. Again, it could be issues with explaining why this change is being made, issues with how the implementation is made, the period it's made over. Many different themes kind of come up, and again, even though this sounds very loosey-goosey, this is a tremendous amount of work. But it is probably the best method I can think of to actually understand why changes do or do not happen and how they succeed. Change management is a theme you're going to hear again and again today, and there's really no better way than this kind of representative sample. A lot of times when a change is made, there's grumbling in the ranks, and somebody at an administrative level maybe hears a little bit of the grumbling, and it kind of filters through that administrative person. This is the way to get kind of the raw, unbiased opinion of what works and what doesn't. Time and motion studies, again, this is really useful insights, a lot of literal legwork. This is where you actually have somebody following somebody within the system with a stopwatch. The majority of time and motion studies are not ever published. These are things like heat maps and other stuff like that. These often get used internally in a big way, and they are one of the best ways to study a change that has been made in a process in the ED. Again, it's very hard. Sometimes if you're looking at patient stays in the emergency department, if you have a clinical pathway, it can be very hard to kind of select the people who fall perfectly within the pathway and do kind of before and after. But this is kind of the way you can really actually see when there's a meaningful change made. It's the sort of study that we need a lot more of in operations research, but there's not a lot of them because they're really just hard to do. Root cause analysis, I'm going to sort of elide through this, but this is kind of a process that really ought to be happening anytime you make an operational change. There are kind of structured methodologies of publishing these, but this kind of goes into a little bit more of change management, and I'm going to leave it for more qualified speakers coming up. Queuing is like possibly, I think, the coolest methodology within operations research. Within emergency medicine, it's very much within its infancy. I'm not going to tell you how to do a perfect queuing analysis right now, but I'm going to just give you a little kind of insight as to why this works and why it's important. So queuing, again, I talk about like operations writ large, industrial operations. Queuing is a standard technique, operations everywhere, I know most people here are probably not from Austin, Texas. You flew here. Maybe you took a train, but probably you flew. And the way the airlines function, every single piece of that goes through a queuing analysis, from when your flight is scheduled to how long you had to wait for your flight to how many of those little containers of like the cookies or pretzels got put in. That almost always will go through a queuing analysis. It's that kind of fundamental of a methodology. And again, like often this is something that really benefits from super granular data. You don't always necessarily need a person with a stopwatch. But the big thing is that the math does get really icky. So I'm going to keep the kind of analysis up here. And part of the other issue is that the results aren't always going to tell you what you like to hear, and that's often why people don't engage in this in healthcare for the most part. This is like my favorite example, I think Leon's too, but triage. So again, I'm not going to make light of triage. Good triage is really hard. It requires a lot of good experience, but I'm going to wave my magic operations wand and say, all right, you got 60 minutes an hour. Shouldn't be rocket science there. Your ED gets 10 patients an hour. Again, this is a little bit mythical. And your triage nurses, having been replaced with robots, see patients every 6 minutes. That's enough. They're that good. They can triage anybody in 6 minutes. So doing my arithmetic as best as I can, that probably says we need like one nurse and like all of our triage will be met. We'll like make this 8-hour shifts so we can like recharge their batteries or whatever. We'll do that, but provided we have the one nurse staffing triage, we're golden, right? People do not seem enthusiastic about this math so far. And that's because whether you know it or not, this is kind of the scenario that I'm predicting with this, and even if I keep all the constraints I told you, even if we only get 10 patients an hour, if our magic triage 9,000 robot, triages them in 6 minutes apiece, the patients, if they come in the emergency department, probably didn't pick an appointment. Instead, they just come in when they come in. So even if I held all of those variables steady, the variation in when patients show up alone is going to get me into really big trouble. And the issue is that any time my nursing triage robot 9000 is not seeing a patient, time is getting wasted, and we're not going to get that time back. Not ever. I mean, again, there are sometimes like things you could catch up on documentation or something like that, but it's not going to help you do the patient-facing part of your job any faster. Comparatively, any time 2 patients come and they overlap, if you have only one person doing the triage, there will be a delay. There's no way for you to like stockpile that time. And any time somebody shows up and there's like a very short interval between them, there's going to be a wait. So what ends up happening is that things get broken down into this ratio, utilization. How frequently is our service getting used, and how long does our service take overall to turn people around? And again, everybody likes it because it's a ratio. It goes between 0 and 1. And there's really, nothing more to it. But as things move, because of that increasing kind of issue with variability of arrivals, the closer and closer you get to 1 in terms of like complete utilization, the longer and longer waiting times are going to be. So in that example, where I said like we had like a 1-to-1 ratio, we had exactly like a lineup between when the patients were coming, how many we needed to see, and how quickly our nurse worked. hits the wall. So like the 1 on this graph is at the asymptote. If you just kind of let that persist over the course of like a day, the waiting times are just going to grow exponentially because you will never catch up. And if you are already not caught up by the time the next hour's worth of patients comes, those waits are going to just keep building every single hour and with every single patient arrival. So usually what happens with a queuing analysis is you determine kind of a level of service. You basically say, on average, it's not acceptable for people to wait more than X amount of time. And again, that deals with this like really uncomfortable reality that people in administration don't like to hear. They want to hear that you are going to create the wait-free emergency department. It's a myth. It does not exist unless you're at an emergency department where you like have hours that go by where you don't get any patients. If you work in a critical access hospital, you may meet that like mythical goal. But if you are like anywhere half busy like the rest of us, there's no way to guarantee that people won't wait. There's no way to guarantee that there won't be a literal bus crash like outside of your emergency department that suddenly gifts you with 30 patients to see. And again, you can't totally defend against those incidents. You can just be able to say, that's really rare, and within the parameters we've set, it's likely that we can get to a point where like 90% of our patients don't wait more than X amount of time. Queuing analysis gets very disturbing because often the number of people you actually need to staff to make a guarantee like that is really, really high, and we are a business that works on very thin margins. So again, like queuing analysis hasn't been used that often, but when it's been used, it's been very effective. Linda Green, she's at Columbia Business School. Her, I believe, husband is an emergency physician, and they did a couple of studies where they basically like took a schedule of emergency physicians, rejiggered it based on a queuing analysis, and were able to cut down wait times considerably. Again, this is for Dunkin' Donuts, this would be like a really standard tool to use, but for us, this is arcane magic. Now again, there are like very sophisticated simulation analyses. There are also very unsophisticated simulation analyses, and there's much more complex methods that if you happen to have access, if you're at a major university and you have an operations research department or industrial engineering there, find somebody and they can hook you up in a big way with the ability to work on these methodologies. Again, the issues with this is that if you aren't part of a major academic center and you don't have access to somebody with the skill set, if you hire a consultant group to do this sort of thing, it's going to cost a lot of money. There are certainly like programs out there that you can get, but you either have to really know a lot of math and programming, or you need to put a lot of investment into it. Again, this is like my perpetual slide. There are tools out there to interested emergency physicians who really want to play around with queuing analyses. Perpetually, they're coming soon, but if you email me, I'm happy to share what I've got. And there are many other methods within operations research. I'm going to breeze through because we have way more interesting speakers coming up. But there are a lot of other domains of operations research which really have not been applied to emergency medicine at all, but have a lot of use cases. In terms of what's happening in operations research, there's a lot of really cool stuff. And again, this is not stuff that has those kind of super complex methods behind it. But kind of the big categories are improving triage, improving workflow within the emergency department, and trying to come up with new pathways. So a lot of us, it's funny, when I got into operations research, I had a senior faculty member say, well, didn't somebody prove that, the fact that there's not a lot of inpatient beds or inpatient bed capacity just going to mean that things are going to be crowded forever? So what's the point of doing operations research? And I mean, it's not as though the guy didn't have a point, but I think we have an incredible amount of latitude to kind of play with the cards we've been dealt. There's a lot of really innovative stuff happening in this field, centered around, how do we make the best out of emergency departments that may be crowded, that may, still have to deal with boarding for many years to come. And there's a lot out there. Again, there's really not enough time quite to go through every single area of operations research in emergency medicine, but really cool stuff that is out there concerns improving times with point-of-care testing, introducing nursing protocols, creating new workflows for triage. Again, this is maybe the most dynamic area within emergency medicine operations. The truth is, boarding is going to be with us probably for years to come, and figuring out how we as a specialty try and get around that and try to provide care and do a better job of kind of improving the paradigm of care. Most of our patients in the emergency department probably don't need to be in a bed. I mean, again, we have an awful lot of patients in the emergency department who are walkie-talkie. If we continue using the paradigm of every patient has to be in a bed, we are probably never going to move along with the increasing demand we have for our services. And again, we have to really, again, think of how are we going to bring care to patients. And alternative workflows are going to be a big part of it. Putting physicians in triage, I love this. It comes with a lot of issues. It's expensive. You have to staff with physicians to do this. There have been a number of studies looking at, can you put a resident at triage? Can you put a nurse practitioner or PA at triage? You can, but a lot of the benefit ultimately gets lost because, again, what you're doing is you're reducing the amount of time it takes to order tests, but you're not necessarily reducing the amount of time it takes to get that patient to the critical decision maker, which is you. And again, there are lots of really cool innovations that center around this. UCSD, I think they came up with one of the most interesting things, which is, again, in California, there are these very fixed nursing ratios, and it really can be a struggle just to get patients out of the waiting room, like far more than most other folks in the United States have to deal with. So literally the response sometimes may be bringing the mobile triage physician robot out into the waiting room. Again, like people are thinking different and thinking weird about these topics, and I think it's stuff we ought to do. In terms of like measurements of productivity, this is still, a major area of research with a lot of caveats to it. And again, trying to understand some of both the workflows and how we actually work as emergency physicians is really quite important. Again, I want to get to our other speakers who, again, I'm the guy who picks out problems and says interesting things about the math to do with them. We have some speakers here who actually will tell you how to fix problems, and I think it's kind of important that we get to that. But ultimately, if you'd like to know more about this or a lot of the topics we have the new SAEM online operations curriculum. So again, this is like a 4-hour workshop. We're not going to get to the whole of how to do operations research, how to do operations in emergency medicine. But rather than spend your entire time at the conference nerding out about this topic with me and with like-minded individuals, you can, from the privacy of your own home, your Peloton, wherever, watch lectures from SAEM members about these topics. These are free. They're generally around 15 minutes apiece, so they're very bite-sized. There may even be contributors to this within this room who have written some really good presentations that dive into these topics. And we have a lot more latitude to go in deep depth on a lot of these subjects. So we currently, I think, have 17 of these posted so far. We've got, I think, at least 10 more that are on deck within the next month to come out. So continue to watch this space. We will take a break. I'm happy to answer questions. And as a courtesy for everybody who's come to this workshop or at least signed up, the giant list of references for every single one of these slides and topics, I'm going to send along a link at the end of the workshop. So rather than listening to me prattle on about how great these studies are, you can take a look for yourself. And again, if you're trying to write your methods section for your next big paper, this is not a bad list to flip through. So with that, we'll take a quick break, and I'm here to answer any questions that folks may have. If we can see people back in maybe 10 minutes, that would be great. Howdy, folks. I don't mean to cut short any like really productive discussions or meetings of the mind or research studies that we may have just germinated here, but in the interest of time, I'd like to get down to like the meat and potatoes of doing operations. So we have both Dr. Wiler and Dr. Clark here. They're going to take you through how to actually like make those operational changes that I've been talking about for the last hour or so. So this is combines both kind of the theory with real life case study, and I'm going to just like step out of the way and let the real experts get to work here. So without further ado, this should be really cool.
Hi, everybody. So yeah, this is where the rubber meets the road. This is really exciting, and I'm a nerd. I'm a math nerd, but I really love being able to see that change happen. And the thing I love about implementing change is everybody has issues with where they work. Like nobody thinks their department, their hospital runs perfectly, and everyone thinks that there's a way to make it better. And this is sort of a roadmap, a case study in how you can do these things. Now, this is a large-scale case study, but the principles apply regardless of the scope or the scale of the change that you want to make. There we go, it is working. So just a little bit about us, just so that you can understand that this applies to you, where you work. This is something that can be done in your setting. And if I stand right here, can you guys hear me? Does the mic pick it up? I hate standing behind a podium. It makes me feel self-conscious and awkward, and so I just try to avoid it. But we are a system. We've got a lot of different hospitals, a lot of different settings. We've got a large tertiary academic center, community hospitals, run the gamut of places you can do these interventions. But we are a large hospital. The primary clinical site is big. We're the largest by volume emergency department in the state. And our current footprint, I want to say we're about 90 beds in our main emergency department. We're seeing roughly 110, 120. We've got an associated OB emergency department, which bumps our numbers up for ED a little bit higher. It gets us into the 150s, 160s visits per year. But we're also not just a clinical center. We're a research center. We're a teaching institution. We have residents. We have med students. We have PA students. We are participating in all aspects of the academic mission of emergency medicine. And you can, and we can, be excellent in all of these arenas. So just to lay this foundation, this is not a clinically focused, clinically dedicated to the exclusion of all other ideas place. We have excellent research in emergency medicine. We get lots of our faculty heavily engaged in the research mission. In the teaching mission, we are a residency program. There's 20 plus residents per year, so it's a 4-year program. We're looking at 80 plus residents rotating through our sites. We've got fellowships in global health, toxicology, ultrasound. We are starting fellowships training APPs in emergency medicine so that we can really fill this academic teaching mission. So this can be done. These ideas apply regardless of the setting. But this is what it comes down to is we teach because we want to provide better care for our patients. We do research because we want to find new ways to provide improved care to the patient in front of us and the patients writ large. And we find ways to make it work clinically and operationally so that we can provide better care for our patients, both the one that we're in the room with, as well as all of the patients that are presenting to our emergency department and in our clinic, in our local clinical environment, in our feeder area. And this is the driving question is how can we do this? How can we provide the better care to provide better outcomes, lower costs? And this is a question of not just clinical efficacy, but also efficiency and resource utilization. Every time, as we talked about in the previous talk, every time there's someone sitting around doing nothing, that's time you don't get back. That is time that is impacting a patient's outcomes. And doing this better, doing this at a lower cost, eliminating that waste from our system is really important to drive down those costs and provide better outcomes. And I know we talk about this a lot. It seems like an easy concept, but actually making it work can be surprisingly difficult. I don't know if any of you guys have tried to drive operational or institutional changes, protocols. Anyone tried that at their hospital? Anyone find that it just went smoothly, or is there huge resistance? Almost every, I see the nodding heads of like with smiles and grins and a little bit of a grimace as they're regretfully thinking back about their processes. There are issues that you need to know, to be prepared for, so that you can overcome them. But we have to do this. We have to do this, otherwise we become obsolete. We fall behind, and our patients suffer for it. And to be honest, our staff, our faculty, they suffer for it too. If you've ever had a chance to switch from, maybe when you were a resident, you rotated at a community hospital that either worked much better or much worse than your primary clinical environment, you can feel the difference in how you approach those shifts, either with dread or with excitement. People know when they're not working well, and it impacts our morale. So this is something that we need to do for our patients and for ourselves. And the barrier that we come up against all the time is the institutional culture. The culture either of the faculty group or the nursing practice or the hospital or what have you. There's always a cultural barrier, something that needs to be overcome. And if you've ever tried this, there's this great quote about culture eats strategy for breakfast, is the saying. I believe, oh man, no, it wasn't Berwick. Berwick was the previous one. I'm going to come up with that at the end of the talk, and if you want the quote, I can give it to you. But the idea is that we can come up with all these great ideas, these new ways of doing things, but if we don't change the culture that is supposed to implement these changes, you don't address that, the probability of failure goes up dramatically. Because there's all these unspoken, unwritten rules that comprise the culture of our working environment, and until we address those, the change that we're working for will experience problems and difficulties. And this is where it gets important to just be very upfront. That this is not about us as someone who's driving change. It's not about the way we've always done things. It is a patient-focused, patient-driven endeavor. And if you can keep your discussions, keep your protocols, everything driven on a patient focus, it can help eliminate the ego, the sacred cows that people have that they just don't want to give up. And so this for us is identifying the circumstances that you need to help successfully drive that change in culture, to get people to look beyond those things that previously they would not consider as an opportunity or an avenue for change. Now this is the fundamental, stepwise progress through culture change. And I'm not going to go into each one right now, but I want you to keep these in the back of your mind as we go through our case study of how to drive change. So, are these, I see people squinting. Are these, you can read these, maybe? Maybe not? Okay. Then I'm going to have to pull up behind the computer, get behind the podium. So, this first three is setting the stage, creating the climate for change. It's about a sense of urgency, a guiding team, and a vision. You got to really, if you don't have those, it's going to be very hard to drive this change. Then, having set the climate, you get a whole group of people together on board with this change. And that's where those ones in green, communicate for buy-in, empower action, and create short-term wins, become important. And then those last two are, once you've implemented the change, how to keep it going, how to keep it from falling off, that you don't have to be there reminding everybody, beating them with the stick of like, hey, don't forget to do this, don't forget, we're doing this now, to make this sustainable. And this is the paradigm that we had when we initiated our change. And we're going to talk about how this paradigm has evolved over time and how it impacts change management in the future. And I believe these slides are given out, but if not, I'm happy to give them. So, yeah, so this is our case study. I'm going to let Dr. Wiler talk a lot more about how we actually use these steps, the scenarios around which we're able to implement a large culture change at our hospital, and the outcomes of that change, to kind of demonstrate these steps in action and be a guide, be an example of how this can be done at very, very large scales. and know that it can be reduced to smaller scales for individual projects that you have. Dr. Wiler, you want to take it over from here? And I'm happy to click through.
Hi, good morning. I'm Jennifer Wiler. For those who weren't here when I did an introduction, I'm a tenured professor at the University of Colorado. I'm currently the Chief Quality Officer for our health systems metro region that includes our academic medical center, some ASCs, about 100 clinics, 4 hospitals, and I'm co-founder of our Systems Care Innovation Center. What we're going to do is talk you through what our journey was at the time as one academic medical center that was part of a young health system that then went on to grow and be the second largest employer in the Rocky Mountain region, second only to Amazon. During that time, I served as executive vice chair, and I want to take you all the way back to 10 years ago around our journey, because I do think, like Dr. Clark said, there's a lot of lessons learned and areas that we failed that hopefully that you will succeed at, that we thought we would share with you here briefly today. So let's go all the way back 10 years ago to 2013. And sadly, actually, we're just about to open another new tower, and we're back at this place, which is a little bit of, it's unbelievable, but also exciting at the same time. So back in 2013, we had huge capacity issues, boarding almost as much as 50% of the time, double-digit hours. We had patient-provider dissatisfaction. We had deaths, sadly, in our waiting room. We were on Divert, which at the time was something that was a targeted community strategy, which now, fortunately, doesn't happen as much anymore. And we were about to move into a new facility. And we knew that if we brought all of our broken processes to our new facility, we'd be in the exact same place that we were before. And these are our hallway beds, but we called it the garden view because you got to look at the little foyer and the area near the lunchroom, which was terrible. So the step one in terms of process improvement, you all know this. How many people have read Cotter? If you haven't, read it. It is the roadmap of how you do change management. Step one is create the burning platform. For us, that was easy. We had literally, sadly, patients dying in our waiting room. We had these boarding issues. Nobody walked into work and frankly felt good about the excellent patient care they were providing. They did the best they could with the resources they had, but it was easy from this perspective because it was very clear to everyone that we were not providing the highest level of patient-centered care that we wanted because of our circumstances in our system. Step two was to communicate our guiding principles. And ultimately, really, that's vision setting. And that's our responsibility as leaders to help everyone understand where it is we're trying to go and the why. And as Dr. Clark said, we are in one of the spaces where it is easiest to get consensus. What's our why? It's a patient. It's not a nurse. It's not a doctor. It's a resident. Having a high-functioning team absolutely is a priority. Our academic mission is a priority. But at the end of the day, if you don't deliver excellent, high-quality patient care, you cannot teach how to deliver excellent, high-quality patient care. So we said our focus would be that we would be patient-centered, we would be disproportionately focused on quality and safety, and that innovation and discovery, i.e. change, right? Innovation discovery is actually change, would be our differentiators. And this was ultimately the focus of our mission, which is to care for those patients who are in crisis. So, well, what is our scope in emergency medicine? We already know this. It's about episodic, unscheduled care. But what I think is our real opportunity, we've seen this over the last decade, we're moving outside of those 4 traditional walls of an emergency department into many other spaces because we understand how to do change management and how to think about being creative and how we deliver care within systems of care. So what are the other guiding principles? To be data-centered and to be accountable. And I think this is really important now that I'm a chief quality officer and actually leading change at the system level of all of these principles I'm showing you now. This is the exact playbook I'm using as a CQO, and our hospital just became a Medicare 5-star rated hospital for the first time in our entire history. So it works. But we have to communicate at the beginning. We are going to hold ourselves and our team members accountable. to the quality standards, to patient satisfaction, and ultimately, high-quality care is actually cost-efficient care. So when I talk to my boss, who's the CEO, right now we're actually trying to do budget cuts, 2 to 4% within our institution. I've said, let's lead with patients. Let's lead with high-value care. Don't lead with 4%. You're going to shut everyone down. They don't care. You care. Your COO cares. My system CEO cares. But what we care about is excellent patient care, and those two things actually go together. They are not a polarity. So, and then ultimately, we have to focus on execution. So we have a burning platform, we've set the vision, now we're gonna focus on, in our DMAIC framework, your lean framework, we're gonna focus on execution. So ultimately, there's not enough time to focus on everything. So you really have to strategize about how to focus on where are your most important areas or biggest problems in order to create your change. Really focusing on non-value-added care, I think, is an important, or non-value-added processes is a really important strategy. And I think this idea of central discipline and local control is one that's really important. Central discipline, local control. What does that mean? From a governance perspective, there are management decisions that have to be made by a small, empowered body. That may be at your system level, that may be at your hospital level, that may be at your unit or department level. But ultimately, local control is around engagement of your frontline teams, or now that I'm in an executive role, it's around our managers, our directors, and our VPs. I think it's a really important principle. And again, you have to be able to say, we're going to surface the hidden curriculum. We're going to talk about what's below that iceberg, or again, to give another description, that we are going to talk about sacred cows. When you give people an expectation, it feels less stressful because they anticipate what's coming. So it's kind to communicate clearly. So if you communicate that you're going to be talking about sacred cows, you're going to talk about nurse-staff ratios, you're going to talk about provider performance. When it's a theoretical, it feels less offensive. Then, when you actually have that conversation, it was anticipated, and you feel that I promise you that there is less friction if you use that as a management tactic. Next, you need to set up your governance models and ultimately expectations. I think this is critically important, and that's any project, process, or team that you put together, that you have a dyadic or a triadic relationship. We are, by nature, very provider-centric. I use the word provider because I mean physicians, in my day job now, surgeons and advanced practice providers, but we are provider-centric. But having your dyadic, either nursing or in the ambulatory space, it may be a clinical partner, an administrative partner, is really important. So showing and modeling that collaborative governance shows to the folks who are on your teams, one, that you are aligned, and two, that you care about the interprofessional perspective, and also it helps to create engagement. So this emphasis on dyads or triads is really important. Communicating your transparency of decision making is critically important. And what I think is really important when you put these interprofessional and interdisciplinary teams together, and when you're anticipating going through a really important change, that you say to your key leaders, listen, behind closed doors, I want to hear every opinion you have. This is an opportunity for everyone to participate, but when we make a decision and we leave this room, we have one voice. I think it's a really important strategy. So this is to speak with one voice. So from a leadership perspective, this is how we stood up our governance model. That's to have our executive team of our department. And then ultimately, we broke out into the work into quality and safety, process improvement, and then operations. I love to say that operations is where it's like Atlas, trying to push that big boulder up the hill, every day slogging, trying to get better. But to me, process improvement is really jumping from curve A to curve B. And you may have the same people sitting in these 3 different meetings, but you might not, especially in terms of who you have from a frontline engagement perspective. And having a focus in each of these areas is critically important because it doesn't let your operational conversation bleed into those other things, right? Especially around quality and safety, for instance. And I'm happy to answer questions at the end more about how we did this because I do think it's important. So ultimately, at the end of the day, it's about increasing what we think are high-value care areas and decreasing those that are not, and also ultimately decreasing waste and cost. So there's lots of ways to ultimately go through change management or process improvement. There's lots of methodologies. Some of them are expensive, like Lean, when you get a sensei and black belts. So we did what every great academic medical center does, and we made up our own methodology, and then we published it, and it was a lot cheaper. This is one of my favorite slides. I literally pulled this out for a talk for our health system the other day. Again, focusing on when we're trying to cut at my health system now from 2 to 4%, over 2 days, they went from 2 to 4%, the CFO decided, and saying, you know, how do we actually communicate to our front lines? What is it that we'd like them to do, even though it's a 4% cut? I said, focus on this, right? This is how we describe with lean principles where there's an opportunity. Find waste in your system. It may be overproduction. It may be intellectual waste, people working below scope. There may be a movement issue, right? The spaghetti diagram. Have you ever written down a spaghetti diagram of your emergency department? It takes you about 30 minutes, and all you have to do is show that one visual, and suddenly everybody gets it. It's a hot mess, right? So how do we simplify? Like those things, that makes sense to people. Anyway, that's that idea of transportation. I won't go through it, but I think this is a really helpful tool when you're thinking about what are opportunities. So this is the PI process that we put together. I'm going to talk you through it briefly. This is where we've published it if you have any interest. So what we did when we first started on this journey was to do a task analysis. Now, we were lucky enough to have a very inexpensive PI person who was junior walk around with a stopwatch, as was described before, is a really great way to do research. And literally, we had them follow around a nurse, follow around a housekeeper, follow around a physician. Why did we do that? Because it helped us to figure out how does somebody spend their day. So all we had to do was an hour over 3 different shifts to see what a nurse did. And then we also looked at what our case mix was with regards to staffing. We looked at our arrivals, and this actually at the time was surprising. Now, a decade later, it's not surprising to any of you. We thought for sure Mondays were worse than anything else, and Sundays were slower than another day. No, not really. Maybe the Monday after a holiday tends to be one of our busiest days like everybody else in the country. But this showed us that really we needed to create our staffing based on our arrivals, and frankly, it's not random. It's right. This is now decades later the same. So what we did is we looked to the literature and looked at best practices. Now this is a very old paper, but where we described around what an optimization of a front-end process might look like. So I think one of the hardest problems, I run a performance excellence team now, PI, project management, quality, and safety. And I think one of the hardest parts around PI is trying to figure out how to scope a problem. Because, right, it's kind of like Goldilocks, not too big, not too small, just right. And so at the end of the day, when we were thinking about how do we lead change to move into our new facility, we broke it up into 3 buckets: front end, the middle that we called the core, and then ultimately the back end. And what we did is using our methodology, we put folks we created rapid process modules, or essentially mini RIEs. I still do this at the institutional level. It's very effective, but essentially it's making sure you have the right executive sponsor, the right process owners, which are co-leads, again, dyadic or triadic of your work, having the right consultant with you, process improvement or project management. I actually have quality nurses on my team who lead this work, and we do modified DMAIC events. But it's about making sure you have the right people in the room and that you have the right pre-work done so that when people get in the room, you can spend a modified amount of time talking about current state, which is one, to learn something, because something always comes up. No matter how much pre-work you've done, how many spaghetti diagrams you've done, someone will raise their hand and they'll say, you know what, on the weekends we don't do that. On the weekends, we actually do X, Y, and Z. So it's really important to get those right folks in the room that are representative of your process, and that you have those people who are your informal leaders in the room when you have these events. It might not be a person who has a formal leadership title, but maybe it's that charge nurse that everybody knows the go-to who works on the weekends. So when you have these events, you want to make sure that you have a lot of your pre-work done before you get in the room. You talk about current state. You set the vision of where you would like to go in a one-day period with your executive sponsors, and then you spend the rest of the time focusing on, how are we going to tackle and solve this problem, and at the end you commit to doing an implementation, one day, which is actually really efficient when you have a lot of expensive resources. And again, we wrote about this in our paper, happy to talk more about it. So when you're looking at current state versus future state, I think simple tools like these are really helpful. Again, 1 hour over 3 different days stopwatch collected this information. And what did it show? It showed for us that our nurses were spending a minimal, and we actually put percentages to this, a minimal amount of time giving medications to patients, which is something that's a topic of scope, and providing nursing-centric care. But they were spending a ton of time transporting patients, they were placing IVs, and they were cleaning rooms to try to help us out. So at the end of the day, this task analysis was helpful because we could actually back end into how many minutes of time on a shift were they spent doing that. We could put a dollar amount. Turns out nurses are very expensive. A dollar amount to that. We can actually buy 2 techs for 1 nurse hour. So it helps us to also start to create a business case that a CFO could understand. And this is administrative data. This is not operational research data, right? It was good enough for us to have a conversation. So we ultimately went into each of these events, front end, core, and back end, and we actually had some subgroups, and ultimately came up with some recommendations that we ended up implementing. And what we did is we converted FTEs. We found out actually our nurses were doing a lot of transport, way below scope. You can actually buy 3.5 transporters for 1 nurse. So we converted FTEs of nursing into transport FTEs. Our nurses were spending a lot of time stocking carts. So we actually created a shopkeeper position to help them keep our main area stocked, and then also our bedside carts. And then we actually converted some of our FTEs into scribes. This is what it looked like. Also, us identifying what the ideal team ratio looked like. And some of the work that was previously shown, we had actually found an intern was almost a -1 in terms of patients per hour, and our 2 put you at about a -0.5 patients per hour, and our 3 finally popped you up to around a 0.5 to a 1, and then an R4 put you at about almost 2 patients per hour. So we used, again, that kind of math to help us understand what a team might look like in a certain area with a certain bed count. And what we wanted to do is change the shape of our team so that we had the lowest cost resources helping to support our highest cost resources, because at the end of the day, it's true, we are the highest cost resource, but we need a team around us so that we are not the constraint in the process like was described earlier. So what we did is we got in a room, we created a process of what we thought throughput and flow would be. We were one of the first academic medical centers to implement a physician intake. We actually don't triage, we actually treat and discharge, treat and release patients. But we were one of the first centers to do that in the country. And we tested it, first with nobody in the room, just with our leadership team. Just a piece of paper. We took our highest volume census day, which now it's embarrassing to say that I think it was 110 patients. Last week we almost saw 400 patients in our emergency department. Back a decade ago we were at about 110. And we took all these cards and then just did a simulation of what our average length of stay is, and based on our process where to sort patients. And then we had 4 rounds of frontline staff come in and run sims with us. Why? Because we really want to test the model? Kind of. Because we want to use it as an engagement strategy and make people feel like they're a part of a team and make them feel like they could give us some feedback. And we wanted if there were great ideas, but it was also a way to educate them. So engage and educate. So really an opportunity around culture. And then we did high fidelity sims in our new facility. We were really lucky to be able to have that. place to be able to do that, and that's where we taught what our process was. Ultimately, our implementation included elimination of triage or intake, which now many facilities across the United States have done. We had a pivot team, which is where we actually eliminated a nurse. CMS, as you know, does not require a medical screening exam to be done by a nurse on arrival. We created standard work. I think this is where in emergency medicine, to be honest with you, operations were very sloppy compared to other disciplines within our hospital and healthcare system. We don't write stuff down, we just do it on the fly. But creating standard work documents, although it feels like another policy or procedure from regulatory, it's actually a really important tool to make sure that everyone truly understands what a process is and that even your leadership team agrees. We actually even created scripting. We created these tools for training, which was important, also to make sure that we could have other folks on our team do the training and not have us be there. It became a force multiplier to have that. Then we created care pathways to describe what our process was. We implemented scribes, which now actually is interesting. In the beginning, they were really necessary. Those were actually our quick win in Cotter's 7 stages of change, right? Create your quick win is stage 2. Our quick win actually was that our chair had negotiated some money for scribes. They actually improved our productivity by 10%. Which for the hospital was like, great, I'm going to, spend some fixed income to get, a 10% productivity bump. The margin was impressive, but we never got it beyond 10%. And now that we have Dragon, it's actually unnecessary, and we're looking to repeal it. We implemented point of care testing. We 5S'd all of our carts. We created a stock room that again was 5S'd. We created a pharmacy in our discharge and waiting area that has very impressive margins, actually. This is one of the highest generating revenue centers within our facility, especially during off hours. And then we implemented care pathways, and we've since published quite a bit on this. And happy to talk about how we implemented those at the point of care and our process for developing them. We also simultaneously created dashboards for operational performance, and we also created them to the provider, nurse, housekeeper, and staff level around what are the metrics that we want to track and trend around different groups. In the beginning, we said we would be accountable, so we created data, and then we asked people to be accountable for performance. Again, there was no surprise. We were clear in our messaging from the beginning, and we let folks help us to co-develop some of this content. Ultimately, for our providers, we actually did create a financial incentive. So although we are all academic physicians, 30% of our comp is academic performance and then clinical care, and I'm happy to talk about that if there's any interest in what that looked like. So again, we said we would be data-driven, and I'm showing you how we did that. And ultimately, we measured our improvement. So this was our median census. So when we opened our doors, we thought in a couple of years we'd go up by about 10 or 15%, which was what the trend was at the time. We ended up going within less than 2 years to a 30% total census increase. Our door-to-provider times, and this has actually been sustained, we were before at hours, and now for the last decade, we've been around 8 minutes, even though we don't have a 24/7 provider in intake, and despite our census increase. Left without being seen rate now for a decade has been less than 0.5%. Our discharge length of stay, you can see in the EDBA database, we're often one of the top decile performers and have been for about a decade or so. Our cost, our overall cost per staffing ratio was actually less. And this is actually what I'm most proud of. NDNQI, I don't know if you're familiar with it, but it's a magnet nurse certification benchmark tool, and we had some of the highest NDNQI nursing engagement scores in the country, 99.9 percentile, after we went through this process of implementing a new workflow in our ED. We also created scholarship, based on all of the components that I talked to you about. So what was our process for doing improvement? What was the actual implemented change? And how we leverage technology to try to improve performance. And then we had a number of places from across the United States and actually the Ministries of Health of the UK, Singapore, and Ireland come to visit us. We had a write-up in the Harvard Business Review, and the advisory board wrote about our change management process. Ultimately, people and process can only take you so far. And so much of the work that we do is part of is interfacing with the electronic health record. And that was really the impetus for us to start our Care Innovation Center. And that's where we partner with digital health companies to grow and scale their software solutions. Because we actually had a huge sandbox. We had a lot of patients. And like what was mentioned before, I failed many times before to get an operations partner at the business school to create models with me, and MedModel is stupid expensive, and so really struggled to try to leverage technology. So what we did is, there's a lot of fabulous ideas that are out there, and there's a lot of wonderful technology. Teams want to sell it to you, or they want you to get a grant so you can be a consultant and you can give them money. But there's actually a strategy around a financial partnership, and that's what we did through our innovation strategy. Through those innovation models, we've actually created a virtual health center, and we've partnered with companies like Bose and Google and United Healthcare. This is one around continuous glucose monitoring. We're creating AI algorithms around virtual surveillance. Anyway, I can go into more about what we've implemented. But at the end of the day, the principles that I talked about in the beginning are the most important around the principles of central discipline, local control, always starting with the patient first, leveraging data and communicating that you will focus on accountability. We'll talk a little bit now about what were the lessons learned in us going through our change management journey.
So this is a huge example of those principles that we talked about put into action, put into real life. And not all of us are going to have a situation where we're building a new emergency department and we get to rework all of our protocols. We often work in established areas with established footprint and practices. And how do we use these principles in those circumstances? And the good news is, while this was a huge scale endeavor and certainly illustrated each of the points of culture change dramatically, they are applicable to small scale projects as well, everything in between. We talk about sacred cows. One of the big lessons that we learned there is getting rid of triage. Like if you were to say at the outset, hey, guess what? We're not going to be triaging people anymore, it probably would not have gone over very well. I can imagine that getting a lot of resistance. But these are the kind of things that are possible when you take the time, you go through these steps, and you look with a very clear focus on patient-directed behaviors, directed outcomes. So it seems whenever you've seen someone successfully implement a change, like, well, that, of course, that one is obvious, that's clear, we totally should do that. It seems easy from the outside, but it is a lot of hard work, and that is what we need to be able to put in to ourselves. It is going to be on us as drivers of change to put in that hard work. So just know that that is what you're signing up for. There's going to be updates. There's going to be communication that you have to do with all of your staff, making sure that they are aware, and you're going to have to show up. You're going to have to be there. You're going to have to be participating in this change. Knowing that you are there, that you're in the trenches with them while these change happens, really gets buy-in from the staff. But one of the key lessons that we've learned, and the Cotter model has evolved with us in this idea, is that there's a C in continuing quality improvement or continuing process improvement. This is an ongoing process. If you view it as an acute, discrete event, it's going to trail off. You're going to revert back to those previous behaviors that is driven by that culture that we've talked about. And this is, at the end of the day, changing processes is about changing the culture around patient care at your institution. It is changing, we have this changing the DNA of where you work. Now, we started with this progression through the steps of quality improvement and culture change. But it has evolved since then. If you look at Cotter, it's changed it now to a cycle. That these things that we are doing is an ongoing, continuous process. You can't just set it and forget it. That you need to always be engaged at an institutional level in these ideas of process improvement and quality improvement. So finding that buy-in, that support from either your department or from your institution somewhere to make sure that this is an ongoing focus, not just something we visit periodically, but a focus and a little bit of an obsession of your department is like we need to be focused on quality. Now, hiring for cultural fit. Now, when you get into this idea, when you bring new people in, this is your prime opportunity to rebuild your culture because you find people that are engaged, that are bought into the system that you are trying to make. Now, we are an academic center. Not everybody that we hire is going to be ops nerds like me. Like, I love this stuff. I think this is interesting. I come and I talk about it. I read about this in my spare time because I'm a nerd. But we are also a research institution. We're also a teaching institution. We're not just going to find people who are focused on operations, but you can get them to buy into this culture by demonstrating how it benefits them in their arena as well. And this is where we get to that tripartite mission of academic centers. Now, we had in our meetings, and we have ongoing in our meetings, representatives from residency, education, from med students. We have our administrators. Of course, you're not going to do these big projects without administration. But we also collaborate with our research group about how we can convert this into good research projects, as well as how can we take their research projects and effectively implement them in our environment. That is how you get their buy-in. We've had conversations about how do we implement this project. Well, we're going to have to be doing this medication. Who's going to be doing it? How can we make sure it happens consistently? And that is how, by bringing everybody in, getting your researchers, your educators, your clinical providers, getting your nurses, your techs, getting the whole organization to be really bought in and see how this impacts the patient care that we're trying to give. Again, just to reiterate, we have been successful since this change in our research, in our education. It can be done simultaneously. They're not mutually exclusive. We tested whether some of the segmental levels of care, we're having APPs focus on certain patients, having that provider in triage or intake, because we don't have triage anymore, but having that provider up front. Are we robbing residents of educational opportunities? It turns out, no, we're not. They get to see these things. But we looked at it because that was concerned and things that we are identified as potential barriers for our educators, and so that we can confirm that we're providing good care for the patient in front of us, as well as for the patients that our residents are going to end up seeing in the future. And so we do this by, again, just bringing everybody together, getting the researchers, getting the educators on board and as active participants in all of these processes. And that is how, again, and bringing people in, and I know we're running short of time, so I'm going to skip through some of these things. Oh, that was it. So at the end of the day, finding this burning platform, finding the idea that you have, the thing that you want to do, often it starts out as pain points for yourself. When I was in residency, it was things around time to collect a UA and a urine pregnancy test. Like, how long does it take to get urine from patients? Why does this take so long? And it was something that bothered me. But presenting my problem, the thing that annoys me, does not get any traction. But when you demonstrate, hey, the time lag for getting a pregnancy test and a patient getting a CT results in this amount of delay, and then we're providing inequitable care to our female patients in terms of time to diagnostics and treatment. That's a patient-centered outcome that gets people to buy in. Other things like getting radiology to buy into some of these new rules around not having to do creatinine testing so often for renal function testing. Well, delays to CT scan impact patient outcomes. Oh, and by the way, radiology, these also delays increase the amount of time where your CT scan is not working, and that is a primary metric for you as a radiologist. So by improving these processes, we're improving your outcomes, we're improving patient care. Finding these learning platforms, finding the idea that really gets people to buy in, getting the group on board, and really keeping that focus on patient care is how you drive and sustain these outcomes. So recognize we're out of time. Questions? How much time do we have for questions at this point? 5 or 10? Yeah. All right. And you don't have to have any, but if you got them, we have the time, and if not, thanks, and we'll talk to you afterwards.
I do have a question.
Absolutely.
So like, we, as conductors, we do have the whole, like, we instituted the intake and provided an ETA concept. But how did you measure that it didn't affect resident education? Because that was like we got a lot of reluctance from the residents and program leadership that, because we are making all the decisions, provided making all the decisions and thinking of it. How do you tell them this does not affect resident education?
Yeah. So part of it was looking at the data of the patient population. Now remember, this is for patients who walk through the front door. So your ambulance arrivals are still going to be coming in, still going to be being seen first by residents, and they're going to get that exposure to initiating workups and evaluations. Additionally, this is not a 24/7 process. So, are they going to not how to learn how to apply the Ottawa ankle rules? No, they're still going to get the ankle sprains, and sometimes those patients come in by ambulance because that's just the way they decide to present to the emergency department. And looking at the pathologies that were assessed, that the residents wanted to have exposure, needed exposure to, as well as just by surveying and doing qualitative assessments of the residents and their education, is how we demonstrated that it did not negatively impact it. I can pull some additional work and send it along to you from our residency leadership, so if you want to grab me after. But that was a concern of the education group, and we looked at that because we heard that issue up front, and were able to address it as we went through our process.
Yeah, add a couple things. So it's fun, a decade or so ago, Dr. Rogers put together a panel around, does something like, is it excellent patient care antithetical to the educational issues, or something like that. And we talked about clinical decision support, and right, like that's going to be going on all the time. For us, 50% of our patients are now cared for only by the provider in intake plus or minus any. So actually, one, our sick patients are getting sent to be evaluated by our house staff. We want to see sick patients, you don't want to see patients, right? So that unless you're not getting that experience somewhere else. Two, by initiating patient-centered diagnostic testing, that doesn't necessarily, there should be lack of variability, i.e. we should have standardization in our processes. So it shouldn't, there's no intellectual growth in trying to figure out, am I going to get an e-engineer testing, right? So what we've been doing is trying to move the conversation upstream about what's ideal patient-centered care. How should we all be in practice? When someone is delivered to you, your job is to find out if something varied from that and give feedback. So we've been more like investigators and evaluators rather than recipients. Does that make sense? And the other thing was get your tail in the room and don't wait for 45 minutes until everything comes back and then evaluate the patient, right? It really then became this opportunity to get into the room and make sure we agree with the attending and they think about their assessment and decision making. And right, and they're on patients for 3 to 5 minutes. Sometimes their stories change. There's more to it. At the end of the day, it's really those patients you're trying to discharge. You spend the most time. The other patients, it's
and just, I think this ties into the idea of a culture change of, we're talking about seeing patients as soon as they hit the room, whereas previous state is patients are waiting for hours. By the time you get to see them, they have results back and you haven't even done some of your history and physical. It's like, oh, well, now I'm just looking at results and applying it to the patient. Whereas with that culture of when an ambulance hits the room, you are meeting the ambulance there. When a patient comes back from intake, you're seeing them within minutes so that you can do your own assessment, add to or detract from what was ordered up front to make sure that it's right. But we're kickstarting those processes for our patients. We go here and then there.
So, in continuation of that question, do you have certain set of providers in the intake area versus any and every of your group?
Yeah, it's a good question. First of all, it's faculty only, so attendings only, no APPs, no residents. Why? Because at the end of the day, so our patient-centered metric was time of missing care. Lots of data and research, pre-hire implementation, post, that show by putting most seniors to a person at the beginning to set that care plan has continuous disproportionate impact on not only length of stay, but also the utilization of other resources like high cost of care, for instance. Yes, we actually have, it's changed over the years, but around the top 1/3 to 2/3 of high performers in intake who work with day shifts as opposed to evening shifts. Now, it used to be our day shifts, right, because of that arrival curve, but with the busiest shifts, we've actually not been so busy, we actually have 2 attendants in our intake area with our 350 census patient count. Again, 50% of our patients never actually hit the back, where, we're talking about folks that are comprehensive cancer center, blah, 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 like really sick patients as many of our academic medical centers are. So it's a really great point. And people rotated in off the list, of the high performer list versus the non-high performer list. That said, we've had lots of conversations about what's the definition of an excellent emergency physician, right? And those, you have to have a lot of psychological safety to have those conversations. Is it because you're fast? Because right, that might not be. So we look at recidivism and return visit rates. Are patients happy with the visit you give them when we get a bill for a level 4 visit and you spend 10 minutes on that? Maybe, right? So there's been a lot of conversation, assessment, training, rescoping that's gone into our process or mind over the years.
And
Sorry, I can ask. So if your intake physician has just, let's say, screened the patient, initiated the care, and then they moved on to the other area, how much of documentation have you do, or are they expected to do?
Yeah, it's a good question. We essentially have 3 walk-in patients. Rarely now because we're so busy, we're about to open another tower and do this whole thing again. Rarely have some ambulance patients. But there's essentially 3 dispositions. One is I can evaluate you and discharge you from
one of the other hidden advantages of having that provider as opposed to an APP or a resident up front, seeing attending the high-level decision maker right there. And with that 50% of patients who never get back to the main part of our emergency department, either are discharged immediately or get a brief workup, that is the waste of having nurses doing significant evaluations, of doing tech, of doing vital signs, doing all these things over and over and over again and following up, frees up all that effort for the patients in Maine, making the Maine patients, where they're higher acuity, more complex, that they have more nursing and tech resources available to participate in their care, improving the efficiency and outcome of those patients as well.
Yeah, so I would say we have a mini nursing assessment for those 50% of patients. It's the standard nursing assessment.
Yeah.
There's been lots of debate and discussion about, what's required and what are nice to have.
Yeah.
Homelessness, substance use, a lot of SDH stuff and questions. Just the other day I was in a meeting and on the inpatient side, our nurses have to do 27 items on their intake assessments in the hospital. And our ED director laughed and she's like, we have more than that ED, right? It's crazy. So we've spent time also making sure that their documentation, the expectations of their documentation engagement is different based on the acuity of the patient.
Yeah. We've got one last question.
Yeah, so a question about how this translates to other departments. So let's say the ED department becomes super efficient, and just as we mentioned, how did the inpatient team or the inpatient side adjust to the new type of people that were coming back and things of the sort as we progressively got more efficient response?
Yeah, it's a great question. And one of the lessons learned we should put on there was, although we communicated with our inpatient colleagues, we failed to appreciate how big the resistance was going to be on the inpatient side. We were in a position where it had been like a 6-hour length of stay, and we went to, you saw, we were essentially an hour and a half over the disposition time. And we turned that on and thought, that's how can that affect the inpatient space? Well, they become very uncomfortable with your handling a patient. If this is a patient safety issue, you're trying to triage people. And there were some cases where some of our colleagues were inappropriately calling the ICU, like, I think I'm having that's crazy, right? And finish your care now. But we had to reset, we spent a lot of time resetting expectations, because when a patient sits in the meeting for 8, 10, 12 hours, a lot of therapeutic interventions occur, a lot of diagnostic interventions occur. So if we were to do it again, we would have communicated, hey, this is going to change. You're going to have more patients who are undifferentiated, and that's what happens in an acute care setting. And before, we were providing essentially observation care as opposed to determining is it appropriate to admit a patient to the hospital. It's a great question. Now, we've now a decade later, and I think we've talked about it. There's been a lot of interventions that we've put in place to try to recalibrate that expectation. Actually, we initially started with inpatient discharge process as soon as the patient is admitted, and we actually, through this, created an observation strategy. I don't know, Sarah, how many notes do we have for hours?
We get 20 currently, 20 medical and 9 psych observation.
Plus the CDO upstairs?
That's including the CDU upstairs.
Okay. But then we still do observation down in our ED. So that's the really important strategy for us. It was actually interesting when we did this redesign. Blue Cross Blue Shield came to us in one quarter, and they were like, "What did you do? What did you do? Your hospital inpatient rate dropped by 30%." And it was actually implemented this observation strategy. And just to say, it really didn't have to doctor the inpatient hospital right? We were managing all those
But actually, I want to piggyback on that. That comes into hiring for a cultural fit. We have a lot of fellows, and we hire people from other institutions. And there is a little bit of that security blanket of, wow, this patient's been here for 6 hours because took us a while to see him, and then we had to get a CT scan, and everything takes a long time. Oh, and guess what? They didn't die during this time. They didn't significantly decompensate. I can feel much more comfortable in my decision to discharge or do whatever. That security blanket, to a large degree, has gone in a lot of our patients. And that is, this is the model that we have built and that we are bought into. And sometimes we get providers like APPs, even some physicians who are not comfortable operating under that sort of making decisions when you have the information back, that they miss that time that they had with patients. And some of that gets put in our observation space, but we have metrics about appropriate utilization of observation. And this really gets down to hiring and having a providers who match your cultural fit. That we do have high expectations, we're highly resourced, and the people that work here enjoy that. They like that resource, and we've had people who have left and then come back to us, saying that they missed how much the way our department worked. So that just really fits into how you shape your culture, not just as the ED and the people that you hire, but how it impacts hospital culture as well.
Kind of along a similar line, have you looked at your adverse events with these patients who get admitted upstairs, morbidity, mortality rates since implementing this?
Yeah. As I say, we have a 9-day follow-up for how many patients return to the emergency department. Are we treating and treating too abruptly, too aggressively? We have not just who comes back, but who gets admitted. Because sometimes people come back because that's okay. Sometimes people come back, that's all right. And we have multidisciplinary and interprofessional conversations regularly with hospital medicine, the surgical, ICU, all of the other groups. We have a robust referral process. And do clinical case reviews. So we have seen that and assessed that and have not noticed a significant uptick in these adverse events. But whenever there is a concern, we review those and make sure that they were treated and addressed appropriately. And that's not just done as an ED exclusive group, but bringing in those individuals from the referring specialties to weigh in and provide input.
Yeah, one of the first things we did when I showed you that governance model, operations, we created that, stood up. PI, we created that process change. We said we had a quality committee, we had a steady committee, stroke committee, but what we actually did was create a safety committee. We call it CCR, safety, dynamic, leader, myself, and a nurse. And ultimately that became, although there were cases to review, it used to be our medical director sitting in the corner making decisions out here.
Yeah, I
Even our small staff, if you can't do it yourself. Our pharmacist actually is a really good partner in those committees, because so much comes up in our space around meds, and then you can either, you can invite people in for reviews, and that's also a nice way to create collaboration with your ICU and other services. Comes up rather than M&M, which is for teaching, right? This is really systems-based learning.
Yeah, and all of,
Sorry, one more thing to say, at an institutional level, we've also got quality and safety incentives at $500 million in our hospital and our school of medicine. And for our resident incentive, it's $1,000. It's actually half the participant in 300 case reviews. Doesn't matter if it's your home department to get their incentive. And last year we had 970 residents get full incentive for participation, and really awesome feedback. We're about to publish our pre-post results around do you think this helps to improve your understanding of system-based care, and do you think essentially you'll be a better doctor because of it?
yeah. And all of our faculty take turns presenting cases at those conferences. So they're not presenting their own case, that they all cycle through and like are given a group of cases that they then present to the committee for discussion, but it involves all of our faculty.
Yeah, the lead presenters will be assigned a faculty member, and something a reminder, and that was for us to sign off on the right advocacy. We had to attest for the leadership of your faculty around participation in systems-based learning. So if you want your department, you want us to attest for you, you've got to show up to this meeting and you're a lead presenter once every 2 months. So that was also going to be extra.
Pretty certain we're done and done. Yeah, like.
Which is nice when I open my email.
I'm like, I can't close it. I don't know what I did.
We do have like an AV guy in the hallway, I think, if worst comes to worst here. But, I am all but dissertation, so let's see how that goes.
All right.
Not, but it'd be great to do so. Yeah, sure.
Came from my residency program. Pretty good, like digital apps.
to get started because I have an hour and a half lecture in about 35 minutes, I think. I was told I should squeeze it into. I'm Willie Baker, as mentioned earlier, and my assigned lecture by Josh a few years ago was quality assurance. He always wants me to write and talk about quality assurance, but I've spent a lot of time with quality, and I haven't figured out how to assure quality. Everybody wants a QA program, quality assurance. So I always put quality assurance in the title, but I really like to talk a little bit about what the Colorado team talked about a little bit in their lectures, about building a culture of continuous improvement. Because it's really impossible to assure quality. Things are always changing. No disclosures. We're going to talk pretty quickly, go over a lot of things. We'll skip some of these slides. You should be able to download them. If not, contact me directly and I will send them to you. I'm currently at UVM. I was in Boston for the previous 25 years. So a little bit about our health network. And University of Vermont. Vermont's a small state, right? So we are a small AMC that serves to us, a rather vast geographic region, at least for the Northeast. And Messina, the light green, we don't own those hospitals. The dark green we actually own. So UVM Health Network has actually more ERs. We have more ERs in New York than we do in Vermont. And Adirondack Medical Center is not ours, but we serve Adirondack, Camden, Potsdam, Messina. Those are all small hospitals. Most of these hospitals are either rural or critical access. Critical access, less than 25 beds, have to be more than 35 miles. So Moses Ludington, which is actually called our Ticonderoga campus, is a freestanding ER. It's 45 minutes from the next closest hospital in our network, which is a critical access hospital, or Porter, which is also a critical access hospital, but you have to cross a lake to get there. So they say we serve about 40,000 square miles. I don't know if that's true, but Adirondack Park is in here on the left-hand side. And Adirondack Park is, how big is Adirondack Park? Anybody do parks in America? Yellowstone, is it bigger than Yellowstone? 3 times the size of Yellowstone. It's 1/5 the area of New York State. It's 6 million acres, which is about the size of Vermont itself. And we serve an area that's bigger than the park in New York. So let's drop on into the lecture. We're going to talk a little bit about measures, design, and management of process, a little bit about approaches to gaps in performance, and as mentioned in the title, I'd like to talk about a culture of improvement. So I never give a quality lecture or safety lecture of any sort without mentioning this one person. And this article, if you ever can pull it up on Google, I'm not going to spend a lot of time talking about it. It talks about much of the credit for Japan's flight to quality, and the making of its world-class reputation goes to quality guru. The Colorado team had Deming in their lecture too. The other person was MacArthur for other reasons. And every system is perfectly designed to get the results it gets. This person was also quoted before. And we're going to talk a little bit about a case. The onion. So this occurred years and years ago. I won't say which hospital. I worked in a number of them. Paper charts back then. And this 54-year-old guy walks into triage and said, this was handwritten. I haven't seen structured text field in Epic yet about I ate a bad onion, but back in the days when free text was allowed, I ate a bad onion. So that's the case we're working off of. And we're going to talk a little bit about QI and QA. And so what do we see here? This person's driving. They're looking ahead, but they're also looking behind. And quality assurance is a lot about looking behind you and seeing what happened in the past, We look at some data. It's mostly individual focused. There's a perfection myth. We shouldn't have any of these events. We shouldn't have any errors. A lot about solo practitioners. I didn't make this up. This is out of a AHRQ textbook. Peer review is generally not, they say ignored in the table. It's generally not as valued. Errors are punished. QI is more system focused. So in the system of driving, you're looking ahead of you. You're thinking about what's behind you. You pass the cyclist. Did I knock him off the road? Or is there a pothole ahead? Fallibility is recognized. Teamwork is emphasized. Peer review is valued. And errors are seen, and this is important, errors are seen as learning opportunities. So Jen had a PDCA, plan, do, check, act. We do also talk about PDSA. So that's a really important component, learn from what happens. And IHI endorses this. I spent a fair amount of time on IHI courses and working with the IHI on this stuff. So, some examples of stuff that we do, and this is really important. I'm going to knock it, and I'm also going to emphasize its importance at the same time. So, credentialing, risk management, infection control, patient experience, utilization review, accreditation. A lot of the activities that go into these topics are really in broad buckets QA. There's QI opportunities there. Some say that you need to do some of the QA work before you get to the improvement part. And what are these measures? So where do we get them from? Everybody knows a few measures, right? And every medical student, door to balloon time. What is it, 90 minutes? And there's all sorts of measures we have. And they have numbers to them too. CMS puts numbers on all these measures. So CMS says there are standards for measuring the performance of healthcare providers to care for patients and populations. These are the standards. You do it this way. If you don't do it this way, then it's a defect. So we try to put things in zeros and ones, binary, and QA is somewhat like that. Okay, we're back to our guy who ate, the 54-year-old male who ate a bad onion. And it's really busy. This is a busy center. And 45 minutes after this patient arrives and tells that to the triage nurse, he's placed in the hallway, and 10 minutes later, out of the literal physical chart rack, many years ago, a resident picks up the patient. 10 minutes, not too bad, only in the room 10 minutes. So where do these measures come from? Is there a room of people that just kind of make up these measures, or is there a lottery? So there's this National Quality Forum, and most of the measures come from there. We also, in emergency medicine, have an organization that's a subgroup of ACEP called CEDAR, and CEDAR produces measures too. This is important because we have a say in it. Otherwise, we wouldn't have a say at all. Well, perhaps we don't have as big a say as would be nice. And then what about other groups besides the CMS that benchmark? I said no disclosures. I have no relationship with the EDBA other than I like the organization. There's about 1,700 participating, probably more now. This number was from 2 years ago. Participating EDs. Most of them are in the US, some in Canada. There's a few scattered ones from other countries. And the annual report covers about 25 data elements. And you could, if you're an EDBA member, you can kind of manipulate the site to compare your ED to a variety of other EDs, in the sense that maybe you have a separate pediatric section of your ED. You can just say you're a pediatric ER and reduce the volume to what your ED volume is and compare it to other places. You can say you're a trauma center. I mean, you should say what you are, but you can compare yourself to other like EDs. And there are measures in there that you won't find in other places, like how many patients per square foot per year you see, things like that. So I said numbers. What about numbers? OP18, ED arrival to departure for discharged patients. There's the left without being seen rate. By the way, the EDBA and there's a movement in emergency medicine to not just look at left without being seen, because elopes and AMAs are incomplete visits too. So the EDBA looks at left without treatment. And then length of stay for admitted patients and decision to departure. What's that time, decision to departure? It's boarding, right? Does anyone else have a different definition of boarding in your hospital? I bet you do. What's that?
Ours is time bound, so they don't feel reporting until they've had that goes for 4 hours.
I see. Okay. So that's my point. So there's a variety of definitions, and some people say 2 hours, 4 hours. Usually it's 2 hours. Sometimes people pick 4 hours. Sometimes there's other numbers. So do we say the door to doctor time starts after whatever? What's a reasonable time? I mean, you don't just show up to the hospital and get whisked into a room. I mean, maybe you do in some places. Not all the critical access hospitals that happen then. But you're not apparated into a room when you magically appear digitally in the computer. So we actually count the minutes. So how come it's not universal that we count the minutes from the time we decide to admit the patient to when they leave? So that's something to think about and advocate for in your hospitals. And the EDBA counts from decision to departure. Unfortunately, those two were retired. Arjun Venkashet and Scott Wiler wrote a nice editorial on this a few years ago, if you want to Google that. But it's not to the it's not to our advantage that those were retired. So other relevant measures in the CMS data set include those that relate to cardiac care, stroke, image efficiency, sepsis bundle. Sepsis bundle, most complicated measure set that the CMS has ever manufactured, and patient experience. So what about cardiac care? So these are the times. You know, the resident presents the case to the attending. 5 minutes later, the attending sees the patient, then walks back to the rack and retrieves that EKG. What do you think was on that EKG? Probably did not meet that 90-minute door to balloon time. So the Colorado crew mentioned, and congratulations, 5-star hospital. There's 429 5-star hospitals in the U.S. of all the hospitals, something like 14% or something like that. Everyone wants to be a 5-star hospital, but not everyone is a 5-star hospital. Do you want to contribute to your hospitals being a 2-star hospital, or do you want to contribute to your hospital being a 5-star hospital? The stars are very important. Have you ever gone on Hospital Compare? They changed the name of the site, but it's Care Compare now. I advise you to do it, but don't be mad at me. It's very addicting. You'll start looking at all the numbers, you'll change the zip codes, and you'll look at different hospitals. And there's the stars domain. You should know this exists, because this is what the board looks at and what's presented at all the important meetings. And you wonder, like, why are they paying so much attention to this mortality, this observed to expected mortality? It's because each of these categories on the left are worth 22% of the score. Most of what we do is in that 12% bucket, and there's a whole bunch, not a zillion, but it feels like that, measures that contribute to only that 12%, including the left without being seen rate. So don't worry, your left without being seen rate is so high. Your patient experience is far more important, particularly on the inpatient side. So this is a complicated set of formulas. You should just know it exists. And this is important to your hospital C-suite, and therefore it's important to you or your medical directors, your quality directors, and so we should pay some attention to it. But there's reasons why it's not so important as well. So how do we improve? We want to get better. So the Colorado team did give you some really solid examples, impressive examples of how they improved. And they went over some of the things that they did to get there. So you need a framework, you need tools, and you need principles. So I'm going to make a case for why principles are perhaps the most important thing. So what about the framework? I'm a huge fan of this. That's my disclosure. If I probably should have put it up there. I've been brainwashed into the Deming way of improvement. And you'll see this this little circle here with the Plan, Do, Study Act, or Plan, Do, Check Act. And you'll see that everywhere as in quality improvement. And then Deming had this system of profound knowledge, which I'm still trying to learn, even though I spent a lot of time learning it. And it has to do with you really need to know an appreciation for a system, understanding variation. You have to build knowledge, continually build knowledge, and the human side of change, the psychology of change. You can't have expertise or success in only one or two of these areas. You need success in all of these areas to have true improvement, that is sustained improvement. So you form teams, you set aims. The aims should be pretty specific. I'm going to do this in this population by this time. Establish some measures, outcome measures, process measures, balancing measures. You do something, it's a success, but it screws up a whole other bunch of important other things. You know what? That's maybe not the best. Select some change ideas and then test the change. You should really test change a lot before you implement it. Otherwise, you're at a higher risk for failure. The greater your confidence that a change is going to be successful, the less testing you have to do. But you should still test. How many times has somebody made a bunch of plans and then all of a sudden, boom, it's implemented, and then you have to walk it back? So let's talk about appreciation for a system. All of us work, well, I think everybody here works in an emergency department. Maybe there's somebody that doesn't. But you think you know your system, right? This guy's looking down. This is one of those railway cars, those street cars in San Francisco. Maybe he does, but probably not. Has any idea what's in that system that drives it. And you really need to engage the frontline workers. It can't just be a bunch of us sitting in an office. We need to go talk to people. I'm always humbled by the things that I do every day that I really have gaps in my knowledge about what were the steps that occurred before I got to do what I did, or what happens afterwards. So we go into a door to EKG improvement process. You want to reduce that time. You're like, well, that's easy. Just put someone in triage and they'll do the EKG. But you really need to process map everything. You know, who are you putting in triage? How does the patient get to the place where they speak to someone who has a clinical background, who understands that what they are feeling or saying is an indication for getting an EKG? What are the indications for getting an EKG in triage? Because the measure is door to EKG time for 10 minutes for a STEMI. But nobody walks in, or very rare does someone walk in and say, I'm having a STEMI. They walk in and say, I ate a bad onion. So originally, in this system, on the left-hand side is when the patient comes in, and like way far away in the process, the patient gets an EKG. So you want to move it forward. You have to understand all the processes. So we're going to skip through some of this to make up some time. And then you're going to get it presented in some C-suite derived or targeted lecture or presentation. One of these stoplight quality reports. So why is red bad? I guess, I don't know, I'm supposed to stop for red. Red always means not good, right? Yellow's, you know, kind of okay. It's not bad, but it's not good, and green is good. So that's all fine for 30,000-foot view, but that's not going to help you get better. It's just going to tell you maybe you have a problem. So you really need to understand variation. And in that system of profound knowledge with understanding variation, this means either you need to know the math or you need to find somebody who can do the math for you. And this math is not that complicated, but for some reason it seems to be elusive for most hospitals that I've worked at. And that is to present the data not in bar charts or pie graphs, but in run charts, preferably control charts. And you don't need a lot of data for control charts. And we could spend actually a number of lectures just on control charts. But the control charts are important because they help you to understand common cause variation and special cause variation, which I'll talk about in just a minute. And they're rather similar. They're data over time. Run charts are more simple. Control charts have limits, which I'll show you in a minute. One uses a median, the other uses a mean. The reason that the control charts can use a mean is because they give you some additional information that helps you interpret what that middle line is. You need more data points, and there's a few more rules that you can apply. So everybody can look at this chart and say, well, this is a p-chart. P-chart uses attribute data. And you can see on the right-hand side, 100%, right? Antibiotics administered within 3 hours. So there's a change. There's a lot of variation off on the left, and then there's some intervention that occurred, and then things seem to be going right, or someone messed with the data just to make it look good, right? But that's a control chart. Now, actually, a p-chart's not the best chart to use for this. There's rare event charts that you should use when what we should look for is failures in this, right? Not look at compliance. So, well, how can it help you? So this is a lot more messy, right? And this is also a control chart. This is an X bar and R chart. X bar and R and X bar and S are rather similar. They just have to do with the subgroup size. Each of those dots is not one case. It's a subgroup. And they're represented by days. And you can see there's a lot of variation. And I like this graph a lot. A med student made this graph for me with raw data, and we searched for presenting chief complaints that included chest pain. And for those of you that work in Epic, you know that you can have multiple chief complaints. And so if it included even chest pain as the third complaint on someone who, back hurt for 6 months, then it was included in this. And then someone got an EKG at some point. And there are some dots there that are way out of line, right? And I like this chart because it tells me, it shows you that data is messy. You get data out of Epic or your EHR, and then you run some analysis on it. Your conclusions are only going to be as good as the accuracy of the data. This data was not cleaned. So this is just raw data that we analyzed, but it's still useful. And so even with there's a couple of points, I don't know what the heck happened on that day, but that's obviously wrong. But then there's this cluster, right? There's a change there. You can see it. Now, this data is kind of messy, right? The dots are not like right in the same place. That's called common cause variation. But the blue lines are control limits, and there's that cluster that's outside of the control limits. Something definitely happened there. It's not just one thing. So what's common cause variation? Common cause variation is just variation, right? It doesn't take you the exact same number of seconds to get to work every day. And an example that is widely used is take a pencil, and nobody has a pencil here, right? You'll go home and do it. And write the letter A 5 times in a row with your dominant hand, then switch it to your non-dominant hand, write the letter A underneath it. And your dominant hand and your non-dominant hand A's will look rather similar, but they won't be exactly the same. But your dominant and non-dominant hand A's will probably look a lot more different from each other. Same thing with your commute. Might not take you the same time every day, but it's probably in some range. And then something could happen, flat tire, snowstorm, accident. That's your special cause variation. So that's the difference between, so what's the special cause variation there? So we found this kind of interesting. We're like, we made some improvements here. All the way on the left-hand side, we have a red line in the middle. That's our middle line for before we implemented our change. Then we implemented our change, and we dropped our door to door to EKG time, so that's great, you know, we love that. Then COVID came along over here on the right, and it went back up because everyone had to, you know, stay away from the patients on the first surge. But what about that crazy thing that happened in the middle? So we actually took a deep dive into those charts and did some analysis, and that's what a control chart can do. It can highlight special cause versus common cause variation, and then you could try to mess around with the data in the subgroups, try to find out, was it weekdays, was it certain hours, was it certain providers, whatever the variables are that are in your system, then you could start drilling down. So this I love because what this was the EKG machine and triage was never reset for daylight savings time. That's a 60-minute difference, and that's what happens in November. So you notice 80-20, that was the difference. So that's why those charts are great. So, you know, then after this, we get a person who walks into triage, vague story, EKG performed, and the CAF team activated. So, you can really affect some changes. Now, this is the second lecture here. That you have the Don Berwick quote. Don Berwick's a great guy. Variation is a thief. It robs from processes, products, and services the qualities that they're intended to have. So you're going to have common cause variation. You're going to have special cause variation. Our job in operations management is to minimize what variation is amenable to minimization towards where you want it to be. That's the simple part of it. So how do you do it? Well, you might have the right answer, but people may not want to adopt it. And then you're flustered. I'm not a basketball fan. Any basketball fans out here? You know who this is?
Rick Barry.
That's not fair. Because he's seen the lecture before.
No, it's in the top of the order.
So Rick Barry would free throw underhand. And he was really good at it. And everybody knows who's a basketball fan, Wilt Chamberlain. But he was terrible at free throwing. So 50%, less than 50% in 6 different seasons. And then they said, like, you know, you got to go to Rick Barry and learn how to do it underhand. And he improved quite a bit. And in one game, he was, 88%. But then, he's like, I don't like this underhand stuff. And he went back to shooting overhand, and he went back to, in the 67-68 season, 38%. I mean, middle school basketball players are better than that. And why did he do that? In his autobiography, he says because he felt like, I'm quoting this, I'm not using the word because I'm making it, but he says, I felt like, quote, I was a sissy. So that's the psychology of change. Even though this is high stakes, big money, pretty easy, proven success, wouldn't do it. So how good can you be? How many people in the NBA have these statistics? This was Rick Barry. And it's not because he alone is the single greatest free thrower. It's because of the technique. It's a better technique. And other people who have adopted this technique have these kind of success rates. But you don't see this in the NBA, do you? Or in your schoolyard basketball, right? So there's probably a lot of things that we could do to do better that we don't do better because of psychology. Talked about the sacred cow and the hidden agendas. There's some hidden stuff in psychology too. So there's a lot of things on the slides that are tips for you to if you're interested. The Big Man Can't Shoot, Revisionist History, Malcolm Gladwell is a good podcast on this. So where are we here on time? Ooh. Well, I started a little late, 10:30? Okay, I'll move quicker. So creating a culture of continuous improvement. So what do you need? You need principles. What are principles? Shared attitudes, values, goals, practices, and then you have employees and staff solving problems every day. That's the magic sauce. How do you get there? Well, I'll go back to Deming. We're not going to go through all of these. But Deming had these 14 points, which, in looking at it, they were really principles. And one of the ones that really resonates the most to me is that transformation is everybody's job. And he really believed that, and I do too. And I think that it can't be totally top down. It's really everybody's responsibility. Now there's the Shingo 10 principles. They overlap a little bit with Deming, but there are some differences. And then when we put together our department proposal, so UVM became a department of academic emergency medicine, right? They were under surgery as a division until less than a year ago. So when I got there, we were still a division. And we put together a departmental proposal, and we really thought about that. And we put principles in our charter. And things like ensuring safety, constancy of purpose, which some of these we borrowed, stole, adopted from Deming and Shingo. Respect, improving constantly, breaking down hierarchies. Hierarchies are inherent to humanity and are necessary to serve some functions. People have titles, people have authority over other people in various circumstances, but hierarchies can be very much of a impediment to progress and change sometimes. And so hierarchies, I think, are often a big barrier. People are afraid to talk. People are stifled with their ideas. So I think understanding hierarchies and how they could be a barrier. Failure to understand why. We look at a gap or a problem and we think we might have the answer as to why that is, but often we have to dig deeper. Why? Why is the free throw percentage not as good as 95 or 97%? Right? I mean, you keep working on one thing, try to improve this, where maybe you shouldn't be doing this, maybe you should be doing this. So understanding why, and that might not be so easy. Failure to change behavior at all levels, very important. We talked about senior management, setting things independently. Tribalism, we experience that a lot in emergency medicine, right? We're affected by everybody, the surgeons, the cardiologists, other folks. Even within our own departments, nursing tribalism, doctor tribalism, maybe you have a PA or NP tribalism. Tribalism is also can be healthy in some ways, but it can be an impediment. And then blaming people. And this is, despite all of our efforts, I think in medicine now to try to get away from this, a lot of our processes still ends up blaming people, or people feel blamed. So driving out fear, I think, is one of my personal pet peeves as far as, not that that's not a good thing, it's a good thing, but fear, I think, is pervasive in medicine. Nurses are fearful, doctors are fearful, we fear getting sued, we fear being sort of spotlighted as we're too slow, or we order too many of this, or we have too many return visits. So I think driving out fear and having psychological safety is very important to our being able to improve. And then medical errors. What was the basis or the causes of these medical errors? Was it recklessness, or was it at-risk behavior? And so I think that driving out fear and looking at the reasons of it are very important. And then some of the other things that happened even more recently, a couple of years ago, even a big case, right, where a nurse was was criminalized. So criminalization of medical errors or adverse outcomes. So these are things that I think we need to still really focus on as individuals and as a specialty and as the House of Medicine. By the way, that's a link to a joint statement about that criminalization of that case. So there's some other resources, and there's some references at the end here as well about culture in medicine and building just culture. And this one at the top, I think, is a really good article. And the podcast, which relates to it, one is in the Harvard Business Review, one is an IHI podcast. I think both of those are available for free. You only get a few free articles from the Harvard Business Review, but this should be one of them. And then reset your cookies, and you'll get a few more. So Jean Toussaint, who was one of the authors and speakers in both of those. If you listen to this is totally free on YouTube. This was at King's College, his lecture. And this is when I go back to QA and the measures. And yes, those measures are important. The CMS has done a lot of work to try to put together a very complicated system for grading your hospital. And at the drivers for that are things that you and I do and the nurses around us and the housekeepers and everybody do every day. But really, what really matters to your patients? And I think that's what we need to think about. And that's why I like this quote. So, in the end, embrace a set of principles, work within a framework. Everybody's a change maker. And yes, QA is important. Identify and address measures that are important to you and your organization. And remember, continuous improvement, controlling quality at the source means less projects. Projects are important. Sometimes we have to do projects. I love projects. But the more people are involved in continuous improvement, the more people think about quality right every day when they're doing their work, the less projects will be. So the other resources will be at the end of the slides. Again, if you don't get these slides, they're not posted, let me know, I'll send them to you.
So yeah, most of the stuff that we've talked about up until now has been really more about like actual important operational things that you need to know about. So the stuff that I'm going to talk to you about briefly is less about operations itself and more about, how you figure your life and whether operations is the right thing for you. So to start, depending on when you are in your career, if you're still in residency, if you're a medical student, if you're early on, do you need a fellowship? Do you need any other sort of like advanced degree? Are there any certificate programs or courses that may be useful? So when I put the slides together, because I had to go in for SAEM for approval this year because of like conflicts of interest and stuff, shortly after that, I think, is when the administration fellowship became ACGME approved. So that may change the calculus and some of this stuff now. So it used to be that there were SAM approved operations fellowships. Now there's going to be ACGME approved operations fellowships. That's a very different standard, right? So before, I think I would have said, is an administration fellowship necessary? Yes, no, maybe, depending if you wanted to stay in academics, probably was going to be necessary. If you just wanted to go to the community, probably not absolutely necessary. I think over the next few years, that calculus may change, and it will, as the years go on, it may become more and more necessary to do a fellowship. So depending on where you are in your career, you may get away without having to do one, or you may have less choice in terms of if you want to do it, depending on what your ceiling may be, right? If you say, I just want to become a community ED chief, I think you may still be okay without doing a fellowship. Right now, 10 years from now, that may not be true anymore. If you say I want to become a hospital CMO, and that's part of my career path,
then, doing a fellowship may become more important as the years go by. In terms of certificate programs, right, which is much less committed than doing an advanced degree, there's a lot of stuff out there that you can do. Both ACEP and AAEM have essentially a similar ED Directors Academy, and these tend to be like a week-long course. I think these are fairly valuable in terms of the amount of information that you get in a relatively short period of time. So if you're going to become like an ED director, if you're going to do an operations fellowship, I think this is a worthwhile course to attend because you get a lot of information that is all relevant to what you want to do in a relatively short period of time. The ED Directors Academy for ACEP is given twice a year. It's always in Dallas. The AAM one, I'm not sure exactly where they hold it or how many times a year, but it's similar. And depending on what your schedule is like, one may be kind of more convenient than the other, but in my mind, they're interchangeable in terms of the information that they give you. But you should consider them. If you're interested in QI, Intermountain Health in Salt Lake City has a multi-month course that they hold. A lot of it is remote, and then there's a couple of times that you go to Salt Lake for in-person meetings. It's a good kind of base if you're interested in QA primarily. But again, depending on what you're interested in, these may be things that you may want to do. In terms of if you don't have an advanced degree and you think you need the extra letters after your name just so people take you seriously, well, there's plenty of the extra letters that you can get. If you're going to do a fellowship, many fellowships will offer one of these in addition, as part of the fellowship. Most of these fellowships will not offer an MBA because MBAs are much more expensive. If you're mid-career, then there's different considerations because you're probably going to be paying for some of these courses out of pocket. There are a bunch of executive MBA programs out there, so you can do these things kind of more at your own pace and remotely for the bulk of it. They are not cheap, but there are things to consider. The issue with a lot of these is that you're going to be spending a lot of time doing coursework that is going to be, I think, mostly tangentially relevant to what you are interested in, but that's the cost of doing business. So if you need the extra checkbox or like rubber stamp, doing one of these may or may not be necessary, again, depending on, if you want to be in academics versus if you're like more kind of concentrated out in the community, like the value of some of these things may be different. Also, if you're thinking about, doing things at the hospital level, some of these, degrees may become more important, right? If you want to be a CEO of a hospital, then having an MBA or an MBA equivalent is probably going to be kind of the cost of entry into that area. If you want to be an ED director, depending on where you are, it may kind of help differentiate you from some of the other candidates. So again, it used to be, I would say, depends. I think over the next few years, we'll see what happens with this new ACGME accredited fellowship, but my expectation is that if you're early in your career, you're going to be in a transition period, and about 10 years from now, it's going to be mostly kind of the price of doing business, doing one of these things. So depending on where you are, it may or may not be worthwhile kind of just getting it done and getting it over with. If you've already finished residency and fellowship, know that there's going to be a kind of grandfather period to be able to sit for the exam. And I think it will close in the next 7 or 8 years. And it's not a trivial amount of stuff that you have to do to be able to sit for the exam. I think some of the requirements are published, but it's still fairly unclear. But you will need to kind of have evidence of significant administrative responsibilities in your hospital that you can document, and then they're going to make you go through a bunch of online courses. And from looking at it, it will probably, if you have a full-time job like we all do, it will probably take you a couple of years to kind of meet all the requirements before you can sit for the exam. And I don't think anybody knows what the exam looks like yet because they're still in the process of building it. But if you're interested in doing that, the time to start looking into it is now. Sir?
How many administrative fellowships
So there's a lot, because it's not just only emergency medicine. There's a lot of other medical specialties that'll be able to like sit for the exam. So emergency medicine is the specialty that's administering the subspecialty board. But just like for critical care, for example, there's a lot of specialties that can be an entry point for this. So anesthesia, I mean, there's, I think, many of the medicine, they can like sit for the exam. It's just bureaucratically, emergency medicine is the specialty that's administering the subspecialty. Does that make sense? So I think there's going to be a lot of them. So the thing that you have to figure out is, what is your goal, right? Are you kind of interested in staying within the walls of emergency medicine? Do you have like an interest in like being outside of emergency medicine, like kind of doing the hospital path, right? Which there's a lot of options in the hospital path. And you also should figure out what your other life goals are, right? Because especially if you're doing operations, if you let it, operations will eat up every single minute available of your life, right? So if you do not carve out time in your life for things other than work, welcome to operations. It will take up every waking moment of your life, right? So figuring out what your other life goals are and just having some contingency plans in case, your initial plan doesn't work out, I feel is always important. And again, it's SAEM, so, we should talk about academics, and you got to figure out what, role academics will play in your life. I'm sure after you heard JJ's lecture, you were like, good God, I can't do like 90% of what he's talking about. I'm here to tell you, most of us that like do operations research do not operate at the level that he does, and that's okay. You just need to find somebody like him so you can leverage off of him and kind of be able to do some of these things, okay? And you can always start small. I think, a lot of the stuff that we're doing now in terms of operations research is stuff that I think 5 years ago we would have never been able to do, but, we've built like small steps and gotten to like something that's very different than where we started at. And again, if you work in an academic medical center, research and publications are just part of the deal, right? And it's part of what like gets you academic promotion. At a lot of places, academic promotion is directly tied to salary, right? So there's many reasons why you should consider this as part of, an important part of your career. So again, the one thing that no one else should be figuring out for you is what is your career plan, because people can tell you what you should do, but at the end of the day, you're the one that has to figure out what other aspects of your life you want to dedicate time to and how all that fits together so you can have a career plan, an academic plan that makes sense for you, right? I mean, other people can tell you, what they think about like what you should do, but at the end of the day, you have to figure out, how many hours of, the limited time that you have, you're going to dedicate to all of these things, okay? So you should have a plan that takes into account the rest of your life. I think people build these kind of academic and career plans and they forget that, maybe you're married, maybe you have a child, or you're planning on having, more than one child, and all those things, require time, effort, dedication, and there's only 24 hours of the day. And you can't expand those number of hours. So unless you want other aspects of your life to suffer, you should take those into account from the get-go, right? And then have contingency plans, because sometimes things don't work out the way you want them to, so you should have like more than one option available to you as things go on. So you've all seen all these Venn diagrams. So this, in my mind, is how you should kind of approach your life and your work, right? So there's 3 circles, and they're the things that you're good at, the things that you like to do, and the things people will pay you money for, okay? Now, hopefully, the things that you're good at and the things that you like to do, that there's some overlap there, right? If not, then you have to figure out the things that you like to do, how do you get better at them so you are functional at them, and then you get that overlap and you figure out who's going to pay me for doing these things, right? Because if not, if you're only getting paid for things that you're miserable at or that makes you miserable, even if you're good at them, I think long term that's not like an outstanding career plan. So trying to figure out, how do I grow the number of things that I'm good at that I enjoy doing, and then figuring out like, how do you present those to someone else so they pay you money for doing them is the way to have like an enjoyable career, right? So if you have a lot of overlap, you're golden, right? This is the goal, right? The goal is to grow things in a way that you wind up doing things that you like to do and you're good at, and you're at an institution that values those things. If you're in a situation where you have this, you have to look for another job, okay? Because if not, you're gonna have a miserable time. And the more miserable you are, the less effective you're going to be, and probably the shorter your career is going to be, right? So you should not be afraid of like kind of saying, okay, this is not working out, I need to look for something else, whether it's looking for something else somewhere else or figuring out, a different skill set that you have that you can kind of develop, so you are not showing up to work every day going like, how many hours till I go home, right? So when we think about outside of the emergency department, these are things you should think about, because there's a lot of hospital positions that I think emergency medicine is like naturally a good fit for, right? So disaster management is like the classic one where like, there's always a medical director for emergency management at most hospitals, especially at academic medical centers. And for EM people, this is like a natural position for them to occupy. Many academic medical centers now have transfer centers to try to like load manage their patients. Again, fairly natural position for like an EM physician to take over. Network development, telemedicine, right? And then there's like the kind of higher hospital level positions, whether chief, CMO, CEO, CQO, right? All those like letters. But these are all things that if you're in emergency medicine and you're already doing administration, they are possibilities for you. It's just a question of, do you want to dedicate the time and effort? Do you have an interest in them? And then kind of thinking long-term about, okay, how do I start getting considered for some of these things, right? To be like a chief medical officer, you need to have like a 10 to 20 year career plan there, right? It's not like you're going to walk out of like your fellowship and congratulations, you're like hospital CMO. But there's interim steps that you can do if that's what, what you want to get to eventually. So to do all this, right, you need to manage your time. If you're doing operations, if you're doing QA, like I've said before, work will expand to manage every second of your life unless you have a plan to avoid that happening, right? And the problem with that is then the next fire that you have to put out will always be there, and then you don't have any time available to actually do the long-range planning that you need to do to be effective at what you want to do. So you need to designate time and carve out time for your long-term goals, okay? You need to try to regularize your schedule. So what I mean by that, right, emergency medicine, right, you need to staff the place 24/7. But if you're doing, like, if you're an ED director, if you're like the director of like QA, like the director of operations for your system, you need to try to like regularize your schedule to some degree to be able to get things done, right? So I do, for example, I work every Wednesday clinically. So Mondays suck. I have meetings from 7 in the morning to like 5 or 6 p.m. And now with Zoom, right, they're like completely back to back. But I know that Mondays and Tuesdays I'm gonna have meetings. Wednesdays I'm gonna work clinically. Thursday I'm gonna have, more meetings. And then what I do, Fridays, I refuse to have meetings, right? Fridays is what I call my no meetings day, because meetings never solve problems, right? Meetings just create more work. So you have to, at some point, have a day where you actually get work done. Does that mean that on Fridays I don't have meetings? No, it just means that on Fridays I get to set my meetings for myself, and I meet with people that I feel like is important to me because it's gonna advance something career-wise, right? So it's either I'll meet with Josh about like some research stuff that we have like on the back burner and we gotta like get done, whatever it is. And then the rest of my shifts, I work on the weekends, okay? And I work them on the weekends for a number of reasons. One, because if you're like an ED director or a director of operations, Weekends is when all the shit happens that nobody looks at, right? Because there's no administrator in the hospital like watching the store. So working on weekends, I think, is very valuable in terms of like seeing what's actually going on when like nobody's watching. And it's also, it states that nobody wants to like have a meeting. So it kind of meets both things. But I know it's hard to like say, I'm not gonna meet with anybody for a full day. But even if you can have a half day that you define as, you know, this is carved out time where I'm doing work, but I'm not like sitting in front of a computer and going to a meeting with somebody else, you'll be able to kind of achieve a lot of your long-term goals instead of like just spending your whole life putting out fires. And then research. Again, it is SAEM, we should talk about research. And you have to figure out, and I can't tell you, but you have to figure out, how does research fit into your whole career? If your goal is to just do the bare minimum at your academic medical center in terms of research so you can get, you know, not fired, that's great. You know, again, it's a choice that you have to make. If your goal is to kind of move up the ranks, get academically promoted, and do all the academic work that's necessary for that, then you need to have a plan. And again, because you're doing operations, you're not going to have a lot of time. So you need to figure out ways to leverage the stuff that you already do to get academic credit for it. The beauty is that operations is essentially constant before and after studies, right? If you're doing operations correctly, you're gathering data, doing an intervention, and then trying to figure out if the intervention worked or not. So you've already done 90% of the work. All this work gets an IRB pass, right? Because under the QA checkbox that you can do for your IRB, you know, you're doing this work for, you know, operational QA purposes, therefore the IRB portion is essentially done. So now all you have is that last 10% of work, which is writing up the information. And yes, you do not have that extra 10% of time. But if you work at an academic medical center, you have residents, you have fellows, you have other people that can help with the writing, and you can help each other out, right? So everybody benefits from this work. And as time goes on, ideally, you build up a network of collaborators so you can kind of share the work and like increase the number of publications. And even if you start very small, if you do this and plan ahead, you know, after a few years, not only will the number of like publications that you have will grow, but the complexity of some of the projects that you do is also probably going to grow. Like some of the things that Josh and I have done looking at, you know, physician productivity. I mean, a lot of that started many years ago when I was doing some research with a resident where we were just looking at, you know, how many patients did EM residents versus medicine residents would see over a shift at BI where we worked at, right? And that was like the initial study. It was like a very simple study. We just looked at IM1s, IM2s, IM3s, and then EM1s, EM2s, EM3s, and just compare how many patients they saw, because there was not a lot of stuff out there as to whether there was a difference between EM residents and IM residents in terms of like productivity in terms of patients, right? I mean, we all know what the answer was going to be, but since it wasn't out there, then, you know, it's an opportunity to publish something. The other thing I would say about publishing is you should have no shame about being rejected. I think a lot of problems that people have when they do kind of research is like they go like, well, you know, I'm not, you know, if the paper's not perfect, then it's not worth it, or if they get rejected on their first go around, then they just give up. My approach has been, I want to get rejected in the first go around, because if I don't get rejected in the first go around, it means I did not shoot high enough to get that paper published, right? And if I get rejected 5 times, it's okay, because the paper's already written, right? You've already done the work, so you keep throwing that thing against the wall until it sticks, right? And slowly over time, you will build more expertise. You'll be able to better understand what journals will and will not publish. You will build a network of collaborators, and it becomes easier as time goes on to get things out there. And I'll stop there so we have a little bit of time to talk. Look at that, a lot less than half an hour.